Yes, we've got Karina, Rami.
Yeah. Can I just ask, is my sign back to front or is it straight up? I've just been trying to put it up.
No, it's fine.
Good, Rami.
Absolutely fine.
You see it back to front, but everyone else sees it the right way round.
Okay, that's why.
Okay. Okay, are we ready to go?
Yeah.
Yep.
Thanks. Okay, so we can start recording. So welcome everybody to our one of our virtual board meetings. I'd just like to welcome you all. Just like you to note that the meeting will be recorded to provide access to the proceedings for those unable to join the meeting, but I do know that we have several people who have agreed and wanted to join, so you're all very welcome. This virtual board meeting will allow members of the public to observe the meeting, but due to the constraints of a virtual meeting, we're not able to ask questions during the meeting itself. There was an opportunity for those members of the public to present questions beforehand. So we kindly request that all members of the public who are joining us today ensure their screens are switched off so that we can help to manage the board meeting. So Iram, am I right in saying that there no questions have been received prior to the meeting?
That's correct, yes.
Lovely. And I've got apologies from Lynn Dalton, Brian Gunson, Alan Pond, Jane Kinneberg and Paul Smith. Is that correct?
That's correct, yeah.
And deputising, I've got Sarah Crotty. I didn't see Sarah, but I'm sure she's there somewhere. Elka Taylor and Claire Malloy. Okay. Iram, is there anything else that we need to just note on the conflicts of interest, please?
So just on the conflicts, so I'm just going to highlight for the winter plan, that's item 13. It's just coming to board today for discussion and approval on areas of support. So therefore, the GPs are not required to excuse themselves at this stage.
Okay, and when we come to matters that have already been approved virtually, which we'll come to, they've already declared their interests and they've been managed, as you say. Okay, I'd just like to highlight for members of the public that are watching this that all of our register of interests are on the Managing Conflicts of Interest page on our main website for the CCG. So I'd now like to go on to item 3, which is the minutes of the meeting held in July the 23rd. So if I just go for accuracy first of all, I think Elka's got something that she wants to mention. So page 1 and 2. Page 3 and 4. Page 5 and 6. Page 7.
Nicholas, page 7, at the top of page 7, item 185.2,
Yep.
There's an error in there. The word not has accidentally crept into a sentence.
Okay.
Has increased. So that not could be removed in the final version, please.
Okay, thank you very much for pointing that out, which of course gives a whole different meaning to what was actually agreed. So thank you very much for pointing that out. Any other matters or inaccuracies that we need to address? So do I have the board's approval? If you could put your hands up if you're happy to approve. Okay, that's unanimous. Thank you very much. So as I stated, there were no questions received prior to the meeting from members of the public. So I now move on to, and I'm not sure who's actually presenting this item 6, but these are the items that were approved virtually. So who's actually talking to this from our exec team?
Sorry, Nicholas, can I just add, before we go on to the next item, we just need to do the action log?
Oh, I knew I'd forgotten something. I'm looking at it too. Okay, so just got it up in front of me. So they're all open but color coded. Katie, is there any comments to make on those? The comments are actually very self-explanatory.
So the first BAF action, that we've got a report about strategic objectives today, and the BAF is an appendix to that, has been updated for Q2. And further down, there's another mention of Board Assurance Framework, the BAF, and our IG manager has supplied some assurance around cybersecurity that was requested by the board, and that's detailed in the action log.
Okay, so does that mean any of them are going to be closed, or are we still open on all of them?
181.420.
Right. That can now be closed.
I think all of them can now be closed, as far as I can see. The Abney, you've got an item on adult community services on the agenda as well. So I think they can all now be closed. Yeah.
Wonderful. Okay. So has anybody else wanted to comment on that? Sorry.
Nicholas. Oh.
Yes, sorry, David.
There's one item in there that I think we just need to close because it keeps coming up, which is the attendance of the UTC.
No.
David, I don't know if it's me or you, but you're breaking up. So
apologies. Can you hear me now?
Yeah, I can.
Yep. So there's an action on regarding the UTC, which about taking board members for a kind of tour. I think we should probably take that down now because it just seems to be hanging on in the action log, and it just won't be resolved for quite a while.
Yeah. Okay, that's very sensible. Okay, so anything else to add to that, Katie or Erin? I'm taking that as a no, so I'm going to actually close those items on the agenda and now move on to item 6. No, Katie, can you hear me? Seem to be having a bit of technical trouble. Can I be heard?
Yes, I can.
Oh,
Yes.
fine. Sorry.
So,
okay. You were going to say something.
Yes. Item 6, the item to approve virtually, is just for noting. They provided an update paper to go with it, but that decision has already been made. It's just to be noted in the board minutes, so there's no need for any further discussion.
Brilliant. Okay, so that is noted. Now moving on to into our strategic discussion. So the first item, which is an attachment for approval, which I'm going to take as read, but Katie, you may want to just highlight the salient points, is the CCG constitutional amendment. So Katie, back to you, please. Okay, yes, to just confirm that this was a decision the board already made to appoint a joint executive team, but the outcome of that is not reflected in our constitution yet. So it's more or less a technical amendment. You've already made a decision that we will have a managing director. We need now to add the managing director to the composition of the board. And then we've got one slight tweak to the standing orders, which is to say that in a reduced quorum where all GPs are conflicted, the managing director is one of the members of the executive team who are also members of the governing body. And then as a sort of for completeness, really, there's a schedule of financial authorization limits, which was approved by the audit committee. And that just shows you how those have changed to reflect the joint executive posts. So the board is being asked to approve those amendments to the constitution. We have confirmed with NHS England that we can do that within our new model constitution, which allows the boards to make non-material changes. And seeing as this is a change that's already been made, I'd ask the board to approve that, please. Okay, right. Thelma wants to come in. Thank you.
I understand exactly what Katie's saying, but I think for the record, in terms of can we not say it's a technical change, because your constitution needs to reflect. And so if we don't change the constitution, then it questions the validity of the decision made. So everything as I agree with, but can we just say it's just a technical? Can we not say that in the minutes, because minutes
Okay.
in the public domain, please?
Okay, Katie.
Yes,
So
thank you.
with that caveat, which I think is really helpful, Thelma, are we able to now approve that? So if I could just have a raise of hands, please. Okay, thank you.
Nicholas, can
Lovely.
I interject?
David, yes.
I've just noticed we've had a member of the public arrive. I think it's John Baker, and you'd asked everyone at the start to turn their cameras off. So I just wanted to ask if you could do that, John. I know that you were more than welcome to the meeting, but just had noticed that you appeared after Nicholas had said that. Thank you very much, John.
That's really appreciated, John, and thanks for highlighting it, David. Okay, so we now move on to David's, the CEO and Managing Director's report. So over to David.
Thank you, Nicholas. Jane Halpin was due to attend today. So what I will do is kick this item off by talking about the CCG and local operational issues. And if Jane joins by the end of it, I will then go back and ask her to talk for the ICS item at the start of the paper, because I think that's the best way to run it. So she is due to attend. So let me talk you through the other aspects. So if you go down to bullet point 2 in the Managing Director CEO report, you'll notice that we're going to talk about some operational issues. That has been really, I think, challenging and impressive time over the last few months, and especially the last month since board, where we've had to progress back into a space of planned care and really step up services again to be delivering support to individuals in our community and ensure that not only is the COVID response managed, but so is the recovery response. So in March 2020, around primary care, the CCGs communicated to practices that the actions taken to pause services to support general practice response during COVID pandemic. The CCG suspended all of the reporting. What we have done now is continue to deliver, though, on the GP enhanced commissioning framework using best endeavours, and all GPs and practices within our patch have done so. But understandably, due to lockdown, social distancing, infection prevention controls and PPE requirements, the activity was reduced. So following the issue of the phase 3 letter from Simon Stevens and Amanda Pritchard, we reviewed the enhanced commissioning framework and identified how we might restart services from the 1st of October. The national priorities for primary care, you'll have seen in that letter, were to restore activity to usual levels where clinically appropriate, and to reach out proactively to clinically vulnerable patients and those who care may have been delayed. And that was a significant impact that COVID created during the last 6 months. It was also asked to make rapid progress in addressing the backlog of child immunisations and cervical screening through specific catch-up initiatives. And there was GPs, primary care networks and community health services should build enhanced support that they are providing to care homes and begin a programme of structured medication reviews. And all of those plans are in place and will be delivered on. The CCGs should work with GP practices to expand the range of services to which patients can self-refer, freeing up clinical time, and all GP practices must offer face-to-face appointments at their surgeries, as well as continuing to use remote triage and video, online and telephone consultations where appropriate. And I think we've come a long way to do that in terms of moving forward in terms of our technological response during COVID, and all of our primary care practices have the equipment needed and the access to online consultations. So in making recommendations for the restart of the enhanced commissioning framework, the CCG took into account all of the feedback from practice managers and GPs, just to ensure that the plan was sustainable, deliverable and achievable, and also recognise the pressures out there. So the enhanced commissioning framework was refreshed to align with the national ambitions that I just discussed, but included things like LD health checks for learning disability, flu vaccinations, and repurposing of an incentive payment scheme that will support all of those actions that are needed to take place. So significant progress has been made. The recommendations have been presented to our Primary Care Commission and Oversight Group, and all of that information is now in line to begin in terms of our recovery phase. So what that describes to me, I think, is as a CCG, we've been really communicative, we've been open, we've been talking to practices throughout this time, and have moved significantly forward in planning going forward into what the next few months will bring to us. A next area I'd like to highlight is the flu programme and supporting practices with winter pressures. So we've approved and granted by Primary Care Commissioning Committee to repurpose our transformation funding. And that was identified to deliver phlebotomy and anti-coag level 4 to support the flu programme. The funding will provide primary care network level support, the delivery of these flu clinics, either individual practice or external sites, and a significant pressure for primary care and the community going forward. And we think this is a positive investment to enhance what will be a challenging and logistical task for the system. Primary care networks and direct enhanced healthcare in homes and structured medication reviews are due to commence on the 1st of October, and the primary care team have been working with PCNs, primary care networks, to ensure that all care homes, including learning disability homes, are aligned to a PCN. The completion date for this was the 31st of July, but we were unable to confirm 100% alignment at that time. But arrangements are in place for all of those care homes to be covered. And we are assuming that that will be a non-issue, and we'll be taking that forward going into the future. Weekly MDTs have now been set up across consultant geriatricians, mental health workers, community and primary social care workers within each locality. And that's really helped drive forward. And that's been in partnership with Central London Health Services. The care homes continue to be offered training in infection prevention control and PPE, and iPads have been purchased and being rolled out in each of the care homes in West Hertfordshire to support the virtual consultations. So we think that coming into winter, where the pressures will increase in this patch, we will be able to securely provide services to those care homes to make sure that the residents there are safe. So significant progress being made, and a big thank you to our colleagues in primary care for moving this agenda on forward and being flexible with the way in which they've been operating over this period of time. Herts Valley's small grants process, we do know that the voluntary sector has become under significant pressure over the last 6 months. We know that financially it's been challenging, but also being able to deliver. But I don't think we would have been able to respond to COVID if we hadn't have had their support throughout this process. The CCG committed to funding the commissioning of the VCS sector to work and support areas such as providing prescriptions, supporting people that are homeless with food parcel drops, a whole host of services that the statutory sector probably wouldn't have delivered as well. And we've done that in partnership with Hertfordshire County Council and the district boroughs as well. A total of 44 projects have been funded and approved by the CCG, and the money was there out to support the essential services that need to be ongoing and expand our response to COVID. 54 projects will have benefited from that £400,000 in the end once we've agreed it and rolled it out. And I think there's a really good spread across the services that focus on stuff like digital exclusion to support people who need to be included, and helping individuals with their mental health and other areas. So it's been a really good way to sustain our volunteering community sector, support them in. A big thank you to the efforts that they've made, and social prescribing that connects to that will continue us in delivering further services going forward. So 4 primary care networks have expressed an interest in working with the hospital and community navigator service and to recruit a second link worker. So all of our PCNs should now have a link worker, and now they're looking to expand that, which will be a really impressive position for Herts Valley's area. And I think nationally we are leading in that space. In terms of cancer performance, Herts Valley has been working with West Herts Hospital Trust and the integrated care system to restore and recover cancer services. There was substantial impact on diagnostics during COVID. However, significant progress has been made at the trust to upstand those services again, and all urgent endoscopies, cystoscopies have been cleared. However, the cancer improvement plan is underway. There are key changes such as one-stop shops and other changes to improve the pathways that were planned that had just started before COVID and will now begin to continue. So we're picking up all of our recover and transformation work And as you'll hear later in the meeting when we talk about ICP around the adopt, adapt and abandon processes, we're using all our learning in COVID to make sure that actually we improve services faster, quicker, and have new models of care where we've learnt over the last period of time. Herts Valley CCG has been working with all our providers across the patch wider than primary care and the voluntary sector to improve recovery. We know that we have recovery plans that are in line with phase 3 of NHS England's ASK, and that is a significant journey that we're going on. A lot of pressure from the centre. There is an expectation that even during the next phase of COVID that we will continue to deliver planned care. And from conversations that I've had with Christine at the hospital and some of their teams, it really does feel like they've got the balance right in terms of where they're going to have protected space, space that can manage and support COVID patients and keep the show on the road in relation to planned care services. So I think we're in a good space, but very challenging moving forward with the expectations that are being put upon the system from us locally as a CCG, but also from NHS England. I'd like to just mention the Watford Urgent Treatment Centre. The UTC has now been operational for 2 months, really successful. The performance levels achieved remain high in terms of the 4-hour standard of 95%. Currently, the weekly performance levels at the Urgent Treatment Centre is 99.5%, and most days it's achieving 100%. We've seen a gradual increase in attendances. I mean, that's what it was there for, to see people, and continues to provide some operational challenges in terms of the emergency department, which are being worked through as a consequence of having people at the front door being seen in the way that they are. But this was what we set out to work on, and we are thinking that it's delivered exactly what we needed to do on the tin at the moment. Herts Integrated Urgent Care, so 111 is challenging. We know that an increase in activity to 111 providers we have seen over the last couple of weeks, a significant amount of parents calling 111 with children who have been sent home, and that has impacted on the capacity of it. And with the rise in COVID symptoms and the virus moving across the country in the way that it has, especially locally in our patch, that's seen a pressure build up in 111 in terms of the capacity. We are looking at that on a daily basis. Our teams are working with HUC to understand what that pressure is and how we can alleviate it, and we'll continue to do that into the winter months. A little bit on children's, really important thread and strategy for this CCG. Hertfordshire-wide children, young people strategy is being developed. We're doing that in partnership with the County Council, with East and North Herts CCG, and as an ICS, will include partners in West Essex as well. This will have to be something that we do broadly across a partnership, because children interface in so many places than just healthcare settings, and actually holistically we need to be looking after not only the children but the families that they live in as well, because we know the best outcomes are achieved through that. So there's going to be a refresh of some of the data from Herts County Council's children plan that was previously existing, and further meetings are taking place with the intention that we will publish our new strategy in December 2020. We continue with our paediatric transformation program. We know that transformation in paediatric services was identified as one of our key priorities for 2021. We've talked about this on a number of occasions at clinical meetings, at commissioning executive, and at board. We are committed to ensuring that we develop this and ensure that areas such as Asperger's and autism diagnosis is managed and improved, because the offer that currently sits out there is not meeting the needs of children and families. We are committed to that as one of our key priorities. I currently chair the Children's Emotional Health and Wellbeing Board, which is a county-wide multi-provider and partnership board. It includes head teachers from primary and secondary and special schools, and does a lot of work in terms of developing what our transformation plan will be around children and young people's mental health. And as you can see, referrals are now back to pre-pandemic levels. Services are working at the pre-pandemic capacity as well. And we've managed to work through some of those issues around adopt, adapt and abandon in terms of new ways of working. much contact remains online and telephone based, and actually that's meeting some of the needs of our young people who like to use technology to interface, and actually will improve hopefully some of the flow through in terms of activity and numbers that our current CAMHS services can see. But we are seeing an increase in referrals to eating disorder services, and that's been observed locally and nationally. Yesterday, we agreed as part of the CAMHS transformation funding that we have that we will increase our capacity for eating disorder services offered to young people, because the numbers have increased significantly, and hopefully that will mean that people get faster, quicker care, and some of this is being thought to have been delivered part of the I guess the outcome of people being locked down during COVID, and how they've had to manage some of the pressures and challenges that young people have faced. So that was one of the key areas I wanted to put out. We've also got increased what's the words I guess support to schools, and the schools are really thankful to that. We've got new and additional school workers that are being added to our current cohort, and that has become a really positive resource that schools have felt, and that's come back to me yesterday from the head teachers. In terms of community services and recovery, we do know that we're now recovering lots of the services that had to be stepped down where redeployment of services needed to take place. We're seeing children's therapies will have all restarted by mid-September, and face-to-face and group interventions and drop-in clinics for speech and language therapy will be taking place. Children's hearing services, community paediatrics and children's eye services will also be started over the next month. The last bit I want to kind of talk about this kind of operational is the West Hertfordshire Hospital redevelopment. Our work has been progressing over the summer to consider the options for the hospital development site. This builds on the work undertaken for the strategic outline case that was submitted to regulators last year and that this board approved. Recent work has been carried out in light of the guidance that we've received from the Department of Health and Social Care, which states that whilst funding constraints still apply, there may be some flexibility in terms of capital funding for this major project. Time is of essence, and it's really important that we move forward with this work. Since then, we've commissioned specialist planning and design consultants who have been working to assess the merits and suitability of possible sites. We went and revisited the greenfield sites as we were to do as part of our outline business case process. And the independent site feasibility study recently concluded that the most acceptable of the several options is to use the Watford site and adjacent land for the emergency and specialist care. The report concludes that building a new hospital on an entirely new site would take longer and be a higher risk to try to develop. So there is a clear requirement to be able to deliver the facilities quickly, and we have had a clear steer that completion to as close to as 2025 as possible is key in our kind of planning for this huge project. The proposed shortlist of sites is now published, along with the survey, which was invited local people to give their views. And it's really important that we connected with our local community to ensure that we had every voice heard. This closed last week, and the results will form part of the papers that will be submitted to the boards of both Herts Valley CCG and West Herts Trust when they consider the options and agree a shortlist. This will be a joint meeting and is being held on the 1st of October, and the meeting is being held in public. And I just want to reaffirm that this document states it's the proposed shortlist of sites. It is not the shortlist of sites. That decision will be made on the 1st of October. So just to reiterate that, the documents that you see online are the proposed shortlists, and we will need to debate that between the CCG and West Herts Trust when we come to our conclusion on what we take forward. In relation to HR and organisation, I think the staff have had a really challenging time, as we've all known over the last 6 months. We were expecting to open our office on Tuesday this week, and we did, and we probably had the shortest opening and closing in history, really, because by midday we'd had the national mandate from the government that said if you can work at home, work at home. And we wanted to make sure that our staff were safe, which has always been the biggest part of our thinking when we were deciding whether to open or not. So we opened up for the morning, and staff came back in the afternoon. We are hearing that staff are actually liking working from home now. There has not been a significant pull on people wanting to go back. And I have to say, I'm really proud of the staff in the CCG of how they've taken on virtual working. We've been able to maintain our boards, our committees. We've been able to work agile. We've been able to step up really quick services like the hot hubs and turn around work in a really efficient way. And I think this is a great way of working. And I'd just like to thank the staff and board colleagues here who have been enabled us taking this on as fully as we can. But it still does leave us with some health and well-being issues in our staff. The idea of opening the office was always to get those staff who are really struggling with working at home for a myriad of reasons, and give them a space to come and work and free their minds and ensure their well-being was looked after. But with the fact that we are now having to close for the foreseeable future, what looks like potentially 6 months, we have things like employee assistant program available. We have mental health first aiders who have been trained and can support individuals. We are doing also health and wellbeing surveys and workshops, and we have the Optima Life survey that takes place that can really provide some supportive outcomes. So that's really key to our thinking, and I think as a board we need to just make sure that we are looking after our staff. And I know our lay and non-exec directors are all linking in with individuals just to do check-ins to see if everybody's okay and get a sense of the organisation. So thank you again for that. With the redeployment of staff, a review of core resources and actions taken by the CCG to support the response to COVID isn't being completed. We've done a review of our recommendations. We are going to probably now, we're going into incident management mode again. We are likely to start thinking about how we redeploy our staff into roles that will manage and support winter. And the last bit is around BAME and survey network updates, and the risk assessments have all been completed with staff across the CCG, and all of those BAME's staff have been adequately considered in relation to their roles. Risk reviewed assessments will be completed prior to any staff returning to forum, and all of that is in place so that we understand our workforce and any of their vulnerabilities that we can support. So that was really the key areas. I just wanted to talk you through it because there's so much in there that the CCG is working on. Jane, I've seen you. What I did was I started off the meeting and went straight to the operational issues with a view that you would land at the right time. So can I hand over to you to cover the ICS update, because I've not touched that.
Okay, yeah, sorry about that. It's always a bit of a challenge when you're moving between meetings to sort of land at exactly the right time. But thank you for that, David. So I will take the paper largely as read and just try and pull out a few sort of particular strands. A lot of the focus has had to be, as you can probably see, on some of the structural and background stuff. So I apologise that my update is by its nature far less interesting than David's, to be blunt with you. But I thought it would be helpful to give people a sense of what was going on in parallel with the operational stuff. We have spent quite a lot of time on probably three main areas overall. First, continuing to fill the joint executive structure, which is now largely in post, and well, as of 1st of October, when formally Rachel Joyce takes on her clinical director role. She's currently on leave this week. We have a couple of posts which we're still seeking to fill, and the primary care transformation post is out to advert at the moment, with a lot of interest externally, and hopefully interviews in approximately a fortnight or 3 weeks' time. The second sort of main area of work has been working to develop both the ICS meeting side, but also participating in the ongoing ICP development side, obviously relevant to this CCG, the West Herts Valleys work. And with David and Nicholas have been looking for how to support that going forward, including potentially bringing in some additional resource to help accelerate things a little bit. And then a lot of the other area of work has been confirming our core priorities to support the work going ahead, and not just sort of you've got a tiny little graphic which kind of hopes to bring it together, but actually then starting to mobilise those work streams, particularly those that needed maybe a bit of reset and refocus. So pulling out a couple in particular. We have done a lot of work. I'm really grateful to Trudy Mount and others, and Christine Allen at West Herts, to really start to mobilise digital as an enabling work stream in a slightly more tangible way. And I know that there have been a lot of conversations with individuals about that in order to get that going. And the other one that has had quite a lot of attention over the last few weeks has been population health management, discussions with the national support people, including a meeting yesterday, Jim McManus at Herts County Council, and a number of others. And the intention is to continue that process over the next couple of months to ensure that we really have got not just some sort of nice headlines, but actually there are clear work programs that sit behind them. There are clearer reporting arrangements so that it's easier to know what's going on and whether it's going in the right direction and at the right speed than I think it is at the moment, unless you are willing to go to quite a lot of meetings which are quite narrative. So that's just sort of to pull out some of hopefully the more salient aspects of that, and hopefully we'll be keeping people much more up to speed with that as we start to now move forwards. So I'll hand back to you, David, at that point.
Thank you, Jane. Nicholas, over to you.
Yeah, okay. So thank you both of you for that very comprehensive report. I mean, as I think everybody can see, there is an enormous amount of activity going on, even though we are operating in this virtual world, and I think an enormous amount of input from all of our partners that I'm sure we'll be hearing about a little bit later on, and also at our AGM that comes up this afternoon. So over to the board for questions, please, or points. Stuart and Rami, I've got, yeah, and Thelma.
It was the first board meeting of the ICS. Can you give us a quick overview on main issues that arose out of that?
Yes, sorry, I should have said that in addition, Stuart. So first formal meeting of the partnership board for the ICS was last Friday afternoon. The priorities areas that I've touched on were part of that, and we also focused on sort of reframing and restating some of the core principles, mindful that there's been sort of evolution of that work. So there was some, if you like, some internal focus. We then had an update on the workforce work stream, and again touching on what I've just said around sort of those priority work areas. The intention is to have more of a rolling programme of those core work streams coming up at board level for scrutiny, for review, for transparency. And we so I think those were probably the main aspects. Stuart, the last one probably to reference is I had a short paper on the sort of probable shape of future governance to sort of just touch base with people around, so suggesting around 5 main sort of areas of subcommittee for the partnership board, some of which already exist, so design and delivery board, for example, but about refocusing again the work through that. And also suggesting probably 3 main sort of executive subgroups, 2 of which probably exist already. We have a regular chief execs meeting, which we intend to continue. There is a regular DOFS meeting, which we want to sort of expand very slightly into a clearer system finance leaders group. And we also want to establish what I put a marker down as called it a clinical senate. I'm not fussed about what it ends up being called, but something that brings together senior clinical leaders from right the way across the patch, that interfaces with ICOGs and ICAGs, PCNs, and so on, so that we've got that clinical leadership really clearly brought in as part of the operational side as well as the committee side. So hopefully it gives you a flavour of it. It was quite a packed meeting.
It certainly was. I think it was Trevor, then Thelma, and then I've lost who was the fourth one. But anyway, Rami, sorry. So Trevor.
Yeah, just really, it's a question stroke comment. Obviously, good to see that both secondary and primary care coming back to normal activity, and you detail that in the paper. And I think both have been working incredibly hard in order to do that. And I suppose NHS England is still expecting activity to continue, but obviously in view of the fact that there may be an increase in COVID cases in the next few weeks, do we know what expectations and plans are for that?
David, can I start up on that? I know you've got a lot more of the actual operational detail, but there were a couple of calls yesterday afternoon which is sort of relevant to Trevor's question. There's a lot of detailed work going on, as you might imagine, to try and predict the geographical likely increase and the time increase, because as was really clear in the first wave, different places got hit at different times. So there's a lot of quite high level in intelligence going on to try and predict that, because it's then material to at what stage you have to try and have your best guess around when COVID activity may start to peak more than it is locally at the moment, accepting that we are seeing an uptick. I think the second bit that is clearly going to be a continuing ask on CCG and ICS staff is the endless filling in of spreadsheets, frankly, to try and track what's happening and try and manage best the balance between ongoing elective activity and managing a surge of both winter activity and COVID activity. And I think it was fair to say that there was quite a detailed discussion about that last night with regional colleagues that probably didn't reach a firm conclusion, but I think they've gone away from it with a much more strengthened understanding of some of the operational realities that perhaps they didn't have before, from both a primary care and a secondary care perspective. So the last thing I'll say on that bit is the best estimate at the moment is we're probably going to see more, and this is east of England wide, it's not Hertfordshire specific at the moment, but their best estimate at the moment is we're probably about 4 weeks out from a more significant number of COVID cases in hospital settings, but the predictions are that the absolute peak will be a lower but probably longer spread out peak than in the first wave.
Thank you for that. I think it's really important that the message gets back that both secondary and primary care are under pressure at the moment, especially with the flu vaccination season coming, and the expectation to be as normal needs to be tempered according to what happened.
Okay, thank you, Trevor. Thelma.
Thank you. I want to talk about staffing, but in particular about BAME and in light of the Black Lives Matters. I will start off by saying the late John Lewis says, if you think something is wrong, the worst thing you can do is not say anything about it. And I think it's rather unfortunate that it has to take a Black person to actually raise it. I know, Nicholas, you and I have had offline conversations about it. I think it's quite disappointing that with everything that's been going on Black Lives Matter, the board, as the strategic leadership of the organization, we have not actually do some kind of introspection in terms of our staffing, but also in terms of our GPs, to see where we are in terms of equality and diversity and giving people the opportunity in all aspects, and what we can do to improve. However, it's always better to start than never to start at all. So I don't know whether people have looked at the people plan, the NHS people plan that came out the 2021, and when, and if not, I think it's something that we should use the opportunity to discuss at the board, the actions that we're going to be taking. There's a particular section there that gives certain targets about, gives certain targets in terms of timelines on things that we should, as all NHS organisations should implement. You know, one of it is recruitment and promotion. The other aspect of it, the other example is leadership and diversity, and the timetable given to us to implement. But although the plan is about staffing, but I think, you know, we need to look across. It's not just staffing, it's our GPs, and also what are our expectations from our delivery bodies. And I am not talking about policies. Most organizations have the most beautiful of policies. I am talking about practical action being taken, implement that you can see. Equality and diversity, Ken Livingstone told us 20 years ago that you need to go to an organization and you see it and you feel it. So it's not paper. So I've raised this, and I think it's a very important issue. And I think this report, which has given us things to do, I think and I do think it's a board responsibility to take leadership, and I do think it should be discussed.
So can I respond to that first of all, Thelma? I think, you know, you make absolutely the points that we need to reflect on, and then there are several things going on in the background that I think we should share with the board. The first is that we're continuing to have a dialogue with Afro Hearts GPs, which is only one part of the BAME community amongst GPs, but it's a very important part. And I think that I've certainly been speaking to Hein, as has David, about coming up with a support and an analysis which we can then learn from and actually discuss as a board. So that's the first thing. I think the second thing I'd just like to point is that we are working, Katie and Iram have been doing quite a lot of discussions with our board governance NHSEI person who I've forgotten, with regards to an associate lay member of our board, and the idea would be that we would actively be looking to recruit, or at least it will be very clear on the advert from the BAME community. And I think that's really important about the diversity of our board. And I know that all four of you as lay members have offered to mentor and support and be part, obviously, actively of the interview process. Now, there are only 2 points of a much larger agenda, and I think that your points are very well made, Thelma, but I'm obviously going to open this up to David or Jane, who may also want to say something, and then obviously others.
I'm happy to chip in, Nicholas and Thelma. I think it's really good that you've raised it to be debated at the board today and discussed, and we've done quite a bit in terms of internally in the organisation, but probably not had the wider discussion here at board as you've just described. We've actively talked about the issues that have been raised during the Black Lives Matter period that's instigated all of this in terms of the conversation with our staff. We've gone out and done staff surveys. We've received feedback and some quite clear feedback on what we needed to work on. If you look at also our staff surveys over the last few years, it did tell us that we weren't doing enough in certain areas, and that we needed to proactively look at our leadership and how we gave aspirational support to individuals across a broad spectrum. So we are currently talking quite a bit internally at exec, and I am with Hein around workforce and how we support using the people plan, as you said, to address and use as a kind of anchor point for some of these stages and steps that we need to take culturally and organisationally going forward. Natasha is going to talk to the people plan today. It's on the agenda, and we'll refer to it as well in terms of some of the works and plans that they are developing going forward. But it is an important thing that we just need to discuss. So thank you for raising it, Thelma. I do appreciate it.
Yeah. Jane, did you want to add anything to that?
Yeah, just in a sort of a similar way to David, although there isn't anything at this board that brings all of that work together, and I think perhaps one thing that he and I need to think about is doing something either next time or maybe the time after that does make it more visible and sort of coherent. But there are a number of other pieces of work that are going on in parallel to the ones that David's mentioned. So at regional level, there is a work stream looking at through the workforce lens, particularly at BAME diversity, tackling racism. That's led by the Regional Workforce Director, and we have representation on that through Tom Carhill from HPFT. We've been asked to stand up a chief exec representative from every ICS area to really take on leadership for that. So Tom's doing that for the whole of the system. Linked to some of the works going on there, looking at not just the risk assessments that have been asked for in terms of staff risk for COVID, which is disproportionately high, as we know, among BAME populations, but also looking at what the actions are that are being taken as a consequence of those risk assessments. So having found out who the people are that are at more risk, what is actually being done actively to mitigate that risk in an individualized way. So there's quite a lot of work there as well. And I think across the patch, looking at supporting OD that addresses both explicit and implicit discrimination. I've just come from the East North Herts board earlier on, where they were reflecting on their own staff survey and some of the additional training opportunities and OD opportunities that are being added, including what's called civility training. So actually it's understanding those often quite subtle and social shrugs or eye rolling or gestures that are perceived as acceptable for some groups and wholly unacceptable for others. So actually to get really into the detail of what makes an inclusive work environment for everybody. And with that addresses racism. So one of the things I'd be keen to do, and I think is a potential advantage of the weirdness of having to go in this circular way around boards, but it does give you a sense of quite quickly, well, are we doing, that sounds a really good idea, are we doing that consistently everywhere? I suspect on this we probably are, but it's going to help do some sort of benchmarking and challenge, I think, Thelma. So I'll stop, Nicholas, at that point.
Yeah, I mean, I'm just conscious that we've got the people plan coming up, and I think Natasha is actually from HR is going to speak. But is there anything briefly you just wanted to add to this before I move on to the next question, Natasha? I've not got any response, so I've just seen something on the chat line. Okay. Okay, I think this is really something that we will acknowledge and we will act on, Thelma. So thank you very much for the question. Okay, I'm going to go over to Rami next, please.
Sorry, let me get there. Can I just say first, it's really quite a detailed review of the substantive support that has been provided both for community primary care and secondary care. One thing that has happened during COVID is that there's been a substantive shift in the use of IT as part of patient contacts. And one of the things that now has almost become the staple of primary care is the use of Accurx, both for photographs, for videos, and also to get photographs so that we can do appropriate referrals, particularly for dermatology. there is a suggestion that that provision will be limited 1st of January 2021, or will be charged to the community. Is there anything in the pipeline to mitigate this, so we don't end up in January with difficulties with an essential part of the new way of working?
I don't know if Trudy's actually on the call, but I'm aware that there is a meeting that is being held in October, scheduled between Trudy, Mike Walton, obviously one of our PCN clinical directors, myself, and a few others. But the important point is that the actual provision of this and the commissioning of this is actually something that is, there are many providers on there. I think we have a provider that's come in sort of very innovatively, and we need to make sure that when we make that decision that we make it with all the facts. But Avni, do you have anything to add?
Yeah, no, that's absolutely right. So there is a framework of providers that actually could provide this. So Trudy is working up a proposal with options that will be coming later at the tail end of this year, say to November, once she's had some discussions in October. So we will be having further discussions on this at Commissioning Exec as well as other forums.
Okay. Okay, Karina, is that a point to this?
Yeah. Yes, I just wonder, Avni, whether we are in touch with what the other CCGR commissionings, the other two CCGR commissioning, with regards to IT in primary care, because, it would be good to learn from the others, the mistakes or also the successes,
Absolutely, Karina. Right. The whole idea is to actually learn from what everyone has done, especially locally in the ICS system as well as regionally, and then to bring up the right options paper as well for discussion.
Really important point. I think the final thing I just add on that is that GPs now probably have far more views on this than they had 6 months ago, having lived and breathed it, and we have a lot of sort of opinions that we're going to have to accommodate when we come to a solution. So, okay, no more than that. Jill, I know you put your question on the chat line, but a really important question. Do you want to just speak to it, please?
Because care homes has been such a sort of matter of public interest, and seeing about how we're moving towards facing COVID at a higher level again and how you're going to manage it. I think public would be reassured to know about lessons learned and that some of the problems which they encountered last time are not really repeated. I think they're looking for that assurance, and also about communication about what's going on. That very pleased to see about the idea of MDs and proactive work, but again, patients' families reported before that they haven't been as informed as they would like to have been during the panic before pandemic earlier on. Is that going to be too?
Okay, Jill. I mean, I'm going to look towards Avni and Claire perhaps just to give us some information on that. But I think Alison as well is waving her hand, and is it Sarah that wants to come in? Yeah, Alison, did you want to say something first? Go on, you're very keen to talk. Okay.
No, it was all I wanted to say is that Sarah Crotty offered a while back to answer this point. So if we let Sarah go first,
that's fine. Absolutely
that's all
fine.
I wanted to say.
Okay, thank you, Sarah.
I think it was really just to say, I think care homes has been in the spotlight, and that some of the criticism is valid, so there are lessons to be learned. But was particularly affected by the fact that the majority of patients in care homes are shielded, and so our traditional methods of communication using face-to-face communications in multidisciplinary teams was extremely hampered by the fact that professionals are trying not to visit care homes to try not to spread the COVID virus. So we've put in quite a lot of technology into our care homes. We have about 170 care homes, and they've all been given means of electronic communication from the home with a multidisciplinary team. And, that's an area of significant investment from the CCG during the COVID period. And also put in weekly multidisciplinary team check-ins working with our community care provider. I still think it's a bit of a challenge because not everybody uses virtual technology, and because the patients are likely to remain shielded. But I think every effort is being made to involve relatives in multidisciplinary team decisions that are being made about the relatives. But I think that we have moved on and we've learned a lot of lessons during COVID. And then specifically about review of the service that's being commissioned, that's starting as we speak. We're asked for comments to be sent in by the end of September. And Jill, I can link you in with the right person to send any comments to. And that will obviously be pulled together during October, and we'll review the lessons learned from that.
Thank you very much.
Thank you. Does anybody else want to add to what Sarah has said? I'm not getting any.
No, Nicholas, Sarah covered it all. And
thank you.
Just to assure you that in terms of, we are now working through in terms of what are the future options. So Karina is obviously has been pivotal in terms of working with us, and so have some of the primary care clinical directors as well, in terms of what the new model of care will look like for the future, to actually enhance, to learn from the lessons that we've had so far, but to enhance the service in care homes and what we can do better.
Yes, Claire, do you mind if I just quickly ask you just to highlight the work that you're doing with the Hertfordshire Cell, we call it the Hertfordshire Cell, in terms of care home and coordination in terms of outbreaks, etc. Just very briefly.
Nicholas, there's a huge amount of work going on. As you're aware, we do have a care home improvement team that are supporting the care homes, and they're working very closely with CCH to ensure that they have all the skills need to manage any outbreaks. There are numerous cells. There's an outbreak cell, there is a care home cell as well. There's an outbreak board, and all of this structure is to manage most effectively any outbreaks and to minimise any risk, but also to ensure that there's robustness coming forward to the second wave. Nationally, we've already been asked about standing up the training for donning and doffing PPE, and we're assuring them that they can. We're making sure the supplies of personal protective equipment will be available as well. So every aspect we are looking at, not in just one area, but within a structure, a governance structure of incident management.
Thank you. Thank you. I think that's really important to highlight. Unless there are any other questions, I'm conscious of time. I'm actually going to draw that item to a close and hope we've been able to demonstrate the very broad areas that the CCG and its partner organisations have been doing. And as I said, more of that at the AGM. So I'm now going to move on to items 8, which is the CCG strategic objectives for 20 to 22, and the BAF, which is an attachment for approval. Now, it's obviously a very detailed document, but Katie, if I could ask you just to perhaps just highlight some of the salient points, and then we can move to any points or discussions. So over to Katie, please. I've got silence. Is Katie still on?
She's on mute, Nicholas. Katie, you're on mute. Okay, I think we might have some IT issues with Katie's broadband.
Okay.
Okay, Nicholas, I'm happy to pick up this paper.
Thank you.
That helps.
Thank you. Yes, please.
So we talked last time as part of the MD report that we were looking to review our strategic objectives. We have obviously going to review them up to next 18 months, so for April 2022. And the idea of that is to align them more closely with our integrated care system and our integrated care provider priorities, so that we have all of this connected together as one place. We know that over the next period of time, we are moving to integrated CCGs in a different way. So therefore, we need to refresh our objectives that reflect the development of the health and care structures. The proposal is really brief, and it does that intentionally, really, because we're trying to work with non-contentious but really obvious steps that we need to focus ourselves on over the next 18 months. And then what we can do is align our priority and our work plans to these objectives. What's interesting is I think this, as you will see at point 2, the strategic objectives are that we will work with all of our local partners and local people to bring about real sustainable change in order to achieve a reduction in health inequalities, better health, preventing ill health and supporting people to stay well, joined up good quality and safe services that patients receive in the most appropriate place. And we felt that actually, if we, as a board and as an exec, we discussed this numerous times, and we felt that these gave the organisation the ability to, one, all reiterate the same strategic objectives, because historically, if you've gone to different parts of the organisation and asked them what are our key objectives, you'd tend to get 10 different answers. And we wanted to keep it short, snappy, simple.
Thank you. So I will very briefly. I'm here. Can you hear me?
We can now.
We
No, I'm
can,
not.
yes.
But I think you've come in yeah. So let me just close this bit and then I'll hand to you, Katie. That'll make it easier, I think. So they were our key objectives, and the board is asked to discuss these and approve them. Exec have debated them, so colleagues.
Sorry, can you hear me now, David? Okay.
Yes, I can hear you now. So as you can see from the paper, hold on a sec, Katie. As you can see from the paper, the board is asked to discuss and approve the strategic objectives, and the board is asked to note the updates to the BAF framework based on this as well. Katie, happy to hand over to you if you can hear me to add anything in, because I know I had to run with your paper then. And you've put lots of excellent work into it.
Katie, are you able to hear us? I think not, actually.
Yeah, Nicholas, we had similar problems on Eastern North Hearts with just certain participants' video and sound lagging significantly behind the rest of the meeting. I suspect it's probably affecting Katie as well.
Yeah. Okay. So I think, David, you've framed that extremely well, and I'm hopefully Katie may come back at some point, but I think we do need to move on with this discussion. So is there anything else that you want to say before we open it up to the rest of the board?
No, I mean, that's all I wanted to cover. Happy to have the conversation. Exec colleagues, feel free to chip in, because we've debated this probably about 3 or 4 times at exec just to refine our thinking. So shop floor is open to questions, Nicholas.
Okay, over to you. I've got Trevor with his hand up. Is it Alison as well? I'm not sure, but Trevor definitely. Yeah, Trevor.
Yeah, I mean, I think the strategic objectives are very clear and simple, and as you say, transferable across the whole ICS. And I think there's nothing there to disagree with. So I think it will help to unify, all the 3 CCGs in simple messaging, and which, as I said, there is really nothing to disagree with. So I'm in favour of those strategic objectives.
Okay.
Thank you, Trevor. I've just to let you the board know, I've been discussing this with the 2 other managing directors, Peter and Sean, and there's no antibodies to this at the current time, and they're happy to take this forward and talk with their boards as well.
Okay. Any other points from the board? Rami.
Can I just say I also support? I think they are clear, they are simple, and I think we need simple things. What I just wonder is whether these can be converted, as we did in the past with HVCCG in our board committee meetings, into some visualized.
I can hear you.
If we can do some visualization of this to make it much easier for us, and maybe put it in the background so that we got it as a guiding force.
Okay, thank you. Thank you there. Karina.
Very quickly, I do wonder how much our member practices know and are aware of this agreed objectives, and what can we do to spread the word, so to speak.
Yeah,
I think that's a good point, Karina. I think once the board has agreed that this is the language we're happy to use, we can then go out and start spreading it, promoting it, and like Rami said, start designing something that makes it accessible, and then we can push it through into our partners and take feedback, because actually it aligns the work under it. I can see Juliet's put her hand up.
Yeah, just to say briefly that, yeah, absolutely. Once these have been agreed, we really want to promote them quite widely. Member practices, obviously, one audience are public, local people. I think what we need to do is to have something that can explain what it means, because it's actually, I mean, obviously I support the way this is worded. What we need to make sure is that people understand what those words mean, and they actually understand what it means that we're going to do in order to deliver those objectives. Otherwise, they are just kind of a little bit apple pie motherhood, which none of us want. So we just need to kind of do a bit of work around that, but absolutely we need to promote them and explain what it is that they mean.
Okay, any other points? Kate, have you got your hand up? Yeah.
I just want to say, I mean, they're very simple, they're straightforward, they're easy to understand. I think it would be a really powerful message if the other two CCGs, if we could all adopt the same strategic objectives. You know, we are working or trying to work now towards being one organisation, and I think if we could get everyone to agree to have the same, it would be a strong message to give out.
Yeah, I'd absolutely echo and reinforce that as the person who's going to have to try and persuade them. But I agree, and I think the fact that they're clear, they're accessible, they're simply phrased, and you know, picking up Juliet's point, I think it should be both non-controversial to have similar statements or ideally identical statements in the other two CCGs, but more importantly, I think that they're going to be accessible to our patients and population as well as something that makes sense.
Yes, I would also add, Jane, also to our clinical directors in our PCNs as well, which is going to be an absolutely vital part of joining it all up together. Katie, I'm going to give you one final throw of the dice to see if there's anything else you wanted to add. I don't know if you're able to come in at this point. No, the IT has definitely defeated us. So I'm going to ask the board now to, you know, is there anything else that anybody wants to raise before I actually formally ask you to approve the proposed strategic objectives? So do I have support to an agreement to just hands up, please, if you're in agreement? I think that's unanimous from those that put their hands up. Okay, and then obviously to note the updates on the BAF since the last report in July, which is obviously taken as read. Okay, I'm now going to move on to, I'm not sure if it's Hein who's going to introduce this item or Natasha. So you're both welcome. Hopefully you're able to be able to speak to us. And this is obviously on the people plan. And just, I think, Hein, just so you're aware, Thelma has raised some very important points in terms of Black Lives Matters and the BAME population. So I think that's really important just to frame that before you speak. So over to Hein or Natasha, please. So we have complete silence. Right, do we have either?
Hi, Nicholas. It is Hein presenting. I think he might just be having some IT issues for this one.
Okay.
Hein had IT issues a couple of weeks ago at Staff Involvement Group, exactly the same thing, where there's a time delay. So whether he's facing those same issues now, I don't know.
Okay.
I'll just say he's not on mute, is he? So.
Yeah, should we just give a bit of silence and hopefully Hein can come in?
He's just put something.
I can try. Can you hear me? No.
No. Okay. Such an important agenda item. Yeah, I think, Hein, we're just suggesting you might come off camera and then maybe we'll get the sound. I think Hein's disappeared now. No, he's still there. He's still there. David, I'm not sure then who would be the best person to introduce this paper. Is there anybody from our exec team that is able to just do a brief summary and lead on that?
So I think, Natasha, are you able to pick this up? Because Hein had mentioned that you would be here and he might not be able to make it at one point.
So, Chair, I hope you can hear me. So can somebody just acknowledge that you can hear me?
Yeah, we can.
Yes.
So we have a delay.
No, it's the delay again, isn't it? So I'm going to message Hein and ask him to come off and then dial in again and see if that works. How about that?
Thank you, Juliet.
Okay, I'll do that now.
I guess, Chair, is it, David, is it worth doing the next item, which Natasha could probably do?
Yeah, I think that would be very helpful. I was just sure. So Natasha, if you're happy to leave
So
until
I
11.
am here,
Yeah.
and I hope people can hear me. I can hear everybody.
Fine, we can hear you. Would you like to introduce the paper, the people plan, please?
I can hear everybody.
I've just sent him a WhatsApp message. I think it's best to move on, isn't it?
I think we'll move on. I think we'll move on. We'll come back. Natasha, are you happy to introduce item 11?
I'll see if I can do that.
Oh.
Stop video. Chair, is that better? Can people hear me now?
Yeah, we can hear you now, Haim. But
can people hear me now?
We can, but I'm just wondering whether we move on to item 11 and see if you can go back in. Let's move on with item 11, please. So, Natasha. So this is the attachment for information, the quarter one dashboard.
Yeah, so I'll take it as read, and I'll just sort of highlight some of the key points. So in regards to our vacancy rate, for quarter one, it stood at 7.63, which actually had reduced on quarter four. This is also reflected in our staff turnover, which also reduced on quarter four. And during that period of quarter one, we had 6 people leaving the organisation, 3 due to promotion, 1 on a fixed term contract and 1 as a unknown, which is a clinical lead.
There's a very long delay, people.
I'll carry on. And 1 due to flexible retirement, and that individual has actually returned. So in real terms, we've actually had 5 leavers during quarter one. Okay. In regards to talent management, I know Haim will be discussing the people plan hopefully shortly. But a great emphasis has been placed on talent management and succession planning and retention. And I'm just going to carry on.
Just carry on, Natasha, please.
Yeah, lovely. And although that talent management group was set up, and that has been running for the last 18 months or so, obviously there's been a lot of change in structure, etc., across the organisation. So that sort of planning, succession planning, and looking at critical roles is going to be re-reviewed, and we're going to be looking at some workshops being launched to assist management during that process for quarter three. Agency spend for quarter one decreased slightly by about 13,000 on quarter four. We did have 6 employees on long-term sickness absence during quarter one, but actually I'm pleased to say that all of those 6 are back and working now within the organisation, so they have returned from sickness absence. The quarter we saw 344 days of sickness absence, of which 251 were actually due to that long-term sickness. So as I said, we had 6 people off during that period. However, the sickness absence rate was actually lower in quarter four and also lower than the national CCG average. So we're in the right direction. The top 3 reasons for sickness absence during quarter one was actually chest and respiratory problems. That actually compared slightly different to quarter four, where we didn't have any of that. And obviously, although they weren't recorded as COVID related, there obviously people were getting those symptoms and maybe were a little bit more, unable to attend work or anxious around that. Other unknown causes and anxiety, stress and depression. So those are the top 3 reasons for quarter four. But in regards to mandatory training, we're at 95.2%, which is a marginal increase on quarter four. And IG compliance was at 94.5, which had actually increased by 1.5 on the previous quarter. The appraisal rate at the end of quarter one was actually only 20.21%. At the time of writing this and submitting this, we're at 60%. And that has actually now increased a bit further. We have extended the deadline because obviously priorities have changed over the last 6 months. But we are encouraging managers to do those appraisals because we think that's an important part of the role and in developing staff and encouraging them. So we're now currently at 72%, but we will be shutting that window sort of within the next week. So hopefully we will have a higher percentage over the next week or so where people are updating what appraisals they've undertaken. So that's sort of a snapshot of the key areas of the dashboard. Any questions on that?
Thank you very much, Natasha, for that comprehensive summary. Any points that we need to make or other comments? Okay, I'm going to so thank you very much for presenting that. Now, either do we have Hein in? Otherwise, I'm going to suggest we take our break 10 minutes early and actually come back at 11:05 when Hein sorted out his IT issues. So Hein, are you there now? It doesn't look like he is. Okay, so can I suggest to everybody that we actually take a 15-minute break? So we'll reconvene at 11:05, which is a bit earlier than we said, and then either Hein or Natasha can actually just quickly run through the people plan, which has already been read and is very self-explanatory. So I'm going to now suggest we break and reconvene at 11:05, please.
So can anybody hear me?
Hein, we can hear you, but we're gonna take a 15-minute break for you to hopefully sort out your IT issues.
So I'm just trying to figure out, Nicholas, can you hear me via the phone or via?
I can hear you. I can hear you perfectly now. So we're gonna reconvene at 11:05, Hein. Is that okay for you?
That's fine. 11:05, I'll dial back in. I'm just not quite sure. So you must be hearing me via the phone.
Sure, I'm hearing you by the phone. Yeah. So I just turn off the rest of your sound, and then that will work.
To do that. It's been such a disaster this morning.
Don't worry. We'll come back at 11:05. Is Natasha able to just briefly talk to it if we do have the same trouble again?
So I think we should be all right now. I think I've figured it out.
Okay, fine.
So I'll dial in maybe just a couple of minutes earlier. Just
Lovely.
To see that we work.
Lovely.
And I do
okay.
apologize, Nicholas.
No problem. That's okay, Hein. We'll speak to you at 11:05.
Hein, use your phone as you just did, Hein. That'd be perfect.
Fantastic. Okay. Cheers.
Bye.
Hi, Hein. I know you're there early. Can we just check that I can hear you?
Sarah, can you hear me?
Yeah, that's fine now. I think it's the background that might be causing the problem.
Not quite sure what it is.
Apparently, Jane Halpin said she had lots of issues at Eastern North Hearts. I think you might have been on that call too.
So I couldn't present at all at Eastern North Hearts because I was about 10 minutes behind them in terms of what I could see and hear. So
I think the background might use a lot of memory and might, you know, if you're a little bit connectivity challenged like I am, I think it knocks you out completely. Fingers crossed, anyway.
Fingers crossed. Let's hope that works.
The sound seems fine now, Heinz. So there we are.
I just want to see if you hear me through the phone or whether you hear me through the mic. I'm not quite sure which one. I've got both on.
So why don't you turn your mic off on the screen and just do it on the phone?
Let me just see how to do that. Nicholas is asking all the difficult questions.
So you'll have a little sound thing that's like a loudspeaker, bottom right-hand side of your screen.
So I've turned off my phone, but can you still hear me?
I can hear you fine now.
Fantastic. It's the background, isn't it?
Okay, well, let's hope that works.
Okay. Well, we'll do it dead on 5 past, Heinz. So you know.
Thank you, Chair.
And I think David has said that he can introduce it if we need to.
No, I'm fine.
Do we think the corporate backgrounds are working?
I think they're okay, Nicholas.
Okay.
Yeah.
The only thing I find is that I seem to see less of people's faces, and so it's harder to see whether they're gesturing. And if people move around, their hair looks like they put their hand up. So that's the only slight difficulty I've got.
It does, whenever you use a virtual background, it does seem to put a blur around you anyway. So even if you haze it, doesn't it? And it gives that odd ghosting effect.
Is there an easy way to the background? I haven't managed to do it yet.
If you go up to audio video on the top of the bar, I don't know if you've got iPads or you're using.
I've got it on a desktop.
Right, so excuse me, for desktop, go to audio video and then change virtual background.
Right.
And
I switched it off. My laptop just wouldn't support it running in the background today. Hence I'm blurred rather than blue.
Blurred or blue. That's a new.
How you use an iPad?
iPad you can still. You need to take it off. You need to download the picture onto your iPhotos, and then when you click background, it will ask you to select a picture from your photos because that's where it stores all pictures.
Where is background? Because I've never been able to find it.
No.
So we sent you this morning an email. We got an email from Louise Manders yesterday. Yeah. So you got the picture on your iPhotos, yeah?
Yeah.
Yeah. So there should be then 3 buttons when you go down to the bottom of the menu, like 3 dots. And then when you click on there should be an option that says choose background or change background. No?
I've got change audio connection, polling, find device, audio device or settings.
I'm on mine.
I'm the same as you, Kate. I can't do it. I can't change it on the iPad.
Ah, okay.
It's actually quite nice on the eye to have a bit of variety of background, so I really wouldn't worry about it. I've just got this sort of thought of a sea of blue, and it might just become a bit overwhelming, and everybody might morph into one.
There is one selected background on Microsoft Teams that is a bridge. And I had a meeting where
everybody was on a bridge,
and it looked like everyone was on the same bridge because it all went along the same box.
Okay, right. We're gonna kick off in a second. Has Jane gone now? Do we think? I think she was only joining us for a short period. I think so.
Yep, she's left now, Nicholas.
Okay, fine. Okay, right. Hopefully everybody's going to come back in division in a second. But I am going to kick off, Hein, if that's all right. Yeah, and we've got the sound. So, Hein, over to you.
So, Chair, thank you very much. And again, my apologies for the delay today. It seemed that I was constantly 5 or 10 minutes behind everybody else's comments or conversation. So, Chair, the paper that I'd like to present is the people plan, the 2021 people plan, and I want to just draw a number of key themes from this paper. I think that this is the first time that the NHS has published a people plan that are very focused on its staff, on its people, and I think it is a huge step forward. Part of the people plan requires of us to have a well-being guardian because there's a strong focus on health or well-being of the wider workforce. And whilst our Freedom to Speak Up Guardians has kindly agreed across all 3 of the CCGs to be the well-being guardian, there's still ambiguity and uncertainty of what that means in reality and what the ask is of the well-being guardian. The Centre has indicated that they're busy developing some guidelines because we need to be clear in terms of what the consequence of that is on our governing body members who takes up this responsibility. Is it just a point of reference? Is it just somebody that can redirect them? Or is there more required from these individuals? And we will get that detail in time to come. I think on the same theme of health and well-being, we've refreshed quite a number of work programs across the CCG, the induction program in terms of health and well-being and how we support our staff. And just on that theme, there's a variety of support services. So we've got a joint EAP, Employee Assistance Program, for all our staff across the CCGs, and we hopefully will be able to expand that very soon to primary care, and I'll speak about that in a moment. We have a psychological telephone line and a specific BAME support line for staff who need some counselling and support in terms of the reality of COVID and what they've seen. And those psychological support lines are supported, and the infrastructure is done through HPFT and ePut. So it's across both Hertfordshire and Essex. Another requirement for us that we are working on as a HR function is to have a look at our KPIs. So you would have seen the dashboard that Natasha has presented. So we are busy refreshing that slightly, and we may have to tweak that a bit, because there is a much stronger focus on requiring us to report our employee relations statistics. Research tells us that BAME staff are statistically much more likely to be taken through disciplinary inquiries. And therefore, the centre has requested that we report throughout the NHS in terms of that breakdown, in terms of how does our employee relations statistics look like. We are also looking at how we do recruitment, implementing unconscious bias training, but unconscious bias training on its own is not a silver bullet. It won't solve the problem, and part of the refresh of the recruitment process is how do we make sure that recruiting managers are appropriately trained and equipped, and that we make sure that we do not, even if it's unintentionally, discriminate during interview processes. Jane Halpin has indicated that she would be the named executive board member for all three of the CCGs for equality, diversity and inclusivity. And you would have seen by now, and if you've read the detail of the report, there's a very strong focus on BAME staff in the NHS. And just for a bit of context, this is something that have been explored since 2004 and probably before. But the then chief exec in 2004 indicated at that point in time that he wanted to see an NHS that is fully representative or fully inclusive of the people that works in it and the population that it serves. It is now 2020, and statistically we've not achieved much. So I think the fact that the centre has now required of all NHS organisations to have a 5-year plan, and in 5 years from now, all NHS organisations should be representative at all levels of its organisation, so right through from the board to Band 2, in terms of the population it serves and the workforce it leads. So there's much more work for us to do in senior levels, senior management development, and in that regard, the People Plan talks quite a lot about leadership development and talent management. Initially, we debated as a system whether we should have a single talent management steering group. And after this meeting, I'm having a meeting with Nick Carver about the ICS ads program and talent management generally as an ICS. And we are looking at how can we focus more on succession planning and talent management so that we can make a success of our inclusive NHS. As has been the aspiration many times, but without success. I think the other 2 points that I probably want to point out is that I've had very successful discussions with primary care, and particularly with the chief execs of the LMC, both in Hertfordshire, Bedfordshire and in Essex. And yesterday we have come to an initial agreement that we want to work much more collaboratively, which I think is a huge step forward for primary care. And I have been a great champion for primary care as part of our One Workforce strategy, so that we can extend the BAME support, the employee assistance support, the psychological support to the entire workforce, and not just that of the CCGs and the providers, but also to the primary care. Chair, I'm going to stop there. I think that I can talk probably for an hour on this topic because I've gone through this report so many times now, but I'd much rather have time for discussion and take some comments.
Okay, Hein, thank you very much for that. Very clearly spoken. So, as I said, we're going to take the paper as read. This is a paper for discussion. Points, please, or comments from the board. Yeah, Stuart.
may I say this is long overdue. It's disappointing. It's good in one way that it's here, but disappointing it's taken so long to get this strategy come forward. But on page 2, you talk about one of the bullet points. The CCGs have agreed to support primary care as part of the one workforce strategy, etc. And the next line down says primary care networks will enable to expand its workforce and to recruit 26,000 new roles to support PCN development until 2023-24. Can you just clarify those a little bit? Do we know what share comes into the CCGs and how we plan for that, and what roles within that 26,000? That's a huge number.
Yeah, so that's a really good comparison, a point to highlight, because the first bullet point that you highlight is one that is absolutely in our control, and something that I've been very passionate about is that if we talk about a one workforce strategy and a one workforce across the ICS, historically, that did not include the workforce in GP practices, because in essence, GP practices are private businesses. What I have challenged my HRD colleagues across the system with is that if we are to extend a psychological helpline, employee assistant, occupational health support to our workforce in the ICS, it will not cost us anything further to open it up to primary care staff as well. And I'm glad to say that I have reached agreement with the system and the 3 CCGs that where there is funding required in terms, for example, for EAP and for the psychological support, Alan Pond has agreed that the CCG will fund that on behalf of primary care, so the practices won't have to pay for that individually. And there's more discussions underway in terms of how can we better develop primary care support from a HR and from a leadership development and a training perspective. And I will work very closely with both Brian and Mike and the 2 LMCs not to overstep the boundaries in terms of what the LMCs want to deliver and what we can deliver. And that was made very positively. With regard to the 26,000 staff, that is, if you've gone into the detail of the report, that is a aspiration of Health Education England to help support primary care to bring in more people. Where those people are going to come from, I cannot answer at the moment. What the breakdown of that is, I do not know. But it goes back to the government's position in terms of bringing 50,000 nurses in. There's always a contradictory discussion in terms of, is there really 50,000 spare nurses somewhere that we can bring in, or how do we develop them? So I'm sorry, I can't give you more than that detail, but I think that's aspirational.
Okay, thank you.
Okay, any other comments or thoughts?
May I come in, please?
Yes, please, Thelma.
Yes. Hi, thank you very much for this report. I am very concerned about this 5-year. What I may not be around for 5 years, but in terms of helping to make a difference, I don't think because the plan says 5-year, we should have a program that achieves it in 5 years. I think we should be bold. I think we should be brave. I think we should show leadership in this area. The other thing is, it sets out A will do this, B will do this, but in translating it into pragmatic implementation, where is the project plan and timetable for all of these things to be done? I mean, to bring it into practice. For example, if you look at the report, this is the plan on a particular page, it talks about recruitment. It says by October 2020, employers in partnership with staff representation should overhaul recruitment and promotion practices. So there's some timelines. And then when it comes to when it comes to leadership, it sort of indicates, it says actually from September 2020. So I am very interested in how we translate this into practice in terms of indicative timelines and the practical things that's going to be done to make sure all these aspirations are met. Like you said, it's taken 20 years. We don't want it to take another 20 years. Otherwise, we might as well pack our bags and go home. But to me, it service. We don't really want to do anything. And that's why I think we need to be bold, we need to be innovative.
Can I respond? Yeah,
please.
Thelma, I absolutely agree with you. And my meeting that I have after this one is exactly that, in terms of how do we make sure that we develop our BAME community, that develop our BAME staff appropriately, and that we create the opportunities for them so that we that we have the right representation across the system. I think that unless we do something dramatically, we run the risk of this just becoming talks about talks again. We have yesterday had a discussion in terms of the bringing alive as ICS the people plan, but there is a lot of commitments in the people plan by Health Education England, by NHSEI, that is very ambiguous at the moment. It is not clear how that will be done and when that will be done. And by whom it will be done. So I think I take your point. I think the point is well made in terms of where's the project plan for all of these. We have regular meetings with NHSI at the moment as the HRD community, whereby we say that, well, it's all great to have this wonderful document as a people plan, but all our boards wants to know, so what? What are you going to do differently and by when? So those challenges are there. For us as a system, I'm working with the wider HRD community to do an implementation plan for what is immediately within our control. And we are looking, in fact, I will meet shortly with Nick Carver in terms of talent management across our system, and how do we bring all of this alive. But it would need some creative and a bold decision making for us as a system, I would imagine.
Okay, thank you, Hein. Any other comments before I sort of draw this discussion to a close? I'm not getting any takers. So Hein, thank you very much for that presentation. I think though that the point that Thelma has made about having I think our impatience actually to get things done quicker is something I think that we'd all probably want to convey back to the system in terms of some metrics, some clearly defined metrics, some transformational change at pace, I think is in a sense what we're requesting from this. So hopefully to make some progress on that.
Chair, I just want to make a final comment. I think you said just before we broke for a comfort break that, and I don't know what the context was of the reference to the Black Lives Matter. I don't think we should do these things because of the Black Lives Matter. I think we should do it because it's the right thing. We should not affiliate to political or spiritual organizations, but to do it because it's the right thing to do, and it is long overdue.
Okay, that's I think that's very clear, Hein. Okay, thank you very much for a rich discussion, and also the earlier discussion that we had from Thelma when we were doing our managing directors and CEO report as well. So which we'll fill you in with later, Hein. Thank you.
Thank you. Will you excuse me, please?
Thank you. Yes, thank you. That's absolutely fine. So now I move on to item 12. Claire, just to confuse you, we took a break a little bit earlier than we planned, so that's why there isn't a break immediately prior to you. So you're very welcome, Claire. Obviously, Claire is living and breathing this, as we all are at the moment, but this is an attachment for information, essentially. Claire, I don't know if you just want to cover any of the real essential salient points, please.
Yeah, of course, no problem. So, I guess the key points is that the board previously signed off a plan and strategic milestones for the ICP, but that was back in March, just as we went into the COVID pandemic. And obviously that has had a significant impact on the work of the ICP for the last few months and in terms of the priorities on which we are now focusing. So what this paper attempts to do is to just demonstrate where we were, why we've changed, and what is looking different going forward. now some new milestones set out that describe what we want to do for the rest of this financial year, focusing particularly on how the ICP works together to support COVID recovery, both in terms of the immediate recovery and how we go into winter, but also how we then learn from the transformation work that's happened over the last few months and build on that and adopt that for longer term, but also making sure that as we do that, we get appropriate public patient involvement, given that nothing has been co-produced in the last 6 months, and we do need to make sure that we're taking patient experience into account. I can see Alison nodding. Patient experience into account, because it has been mixed, and we need to make sure that as we move forward, that's reflected. There is a plan on the page that I'll just draw people's attention to. That's our sort of first attempt at trying to say in one place what it is that we're doing and how we're approaching it, and to bring together all the different strands, both of the ICP development, but also of service change, COVID recovery, and also now how we start to think more strategically as an ICP and bring us an ICP view and perspective into key strategic issues, the first of which is the redevelopment for West Herts hospitals, and how we ensure that actually everyone understands and is committed to the work that needs to be done to be able to safely transform services from where they are now to where they would need to be as we move into that new building in 2025. So that's probably enough, Nicholas, from an introduction from me, if there are any questions.
Thank you. Just as a quick rider on this version, we have slightly changed it as a result of the ICAG discussion that we had.
Oh, you're muted.
Sorry. So just as a result of the ICAG, we now have clinician and practitioner-driven transformation delivered through co-production and strong relationships as a very central theme on that page. But really over to comments, please. As I said, we are living and breathing. Alison's got her hand up first. Thank you.
Hi, Claire. I'm really pleased that you mentioned, because that was going to be my primary question, but I just wanted to comment on the idea that although we haven't been able to do co-production within the last 6 months, I think it is possible to learn from the experience of patients during this COVID position. A really good working example is the Maternity Voices Partnership that we have at West Herts Hospital Trust. Through an accident of fate, I've ended up attending that meeting quite regularly, and it has continued through the crisis, and it has also adapted how in order to question their experiences of being, using maternity services during the period, and how those have been different. And that's been specifically so that where things are going to be similarly difficult, we can learn from some of that stuff. I just wondered if, as well as our commitment to going back to involvement and co-production, I just wondered if we've got any other activity going on to make sure we learn COVID-related lessons from the experience of patients.
So I think that's a very good question. I think one of the things that we haven't yet managed to do as an ICP, and which is coming back up the agenda again now that we're in a slightly different place, is we know that there is really good co-production going on in lots of our individual organisations, though sometimes more in some parts than others. And maternity is a good example of something that's done well at West Herts. What we haven't really managed to do is to work out how we join that up across the ICP and make best use of that to inform the work we do as an ICP. So that's one of the things that Julia and I are talking about, really getting that piece of work going again. So I think that is something that we need to do, and is not quite there yet. I think that the focus has been where we know that we have not involved people, and the specific changes we had to make in response to COVID, such as virtual consultations and discharge to assess. So some of those things where actually it is now important to pause and take stock, because I think they're things that clinically and professionally people think are really good things to do, but we must take account of the patient experience and work out where that doesn't work, and how we therefore meet the needs of everybody, not just those who are digitally enabled.
Yeah, I think again that there's a lot of emphasis on the moment on how things are going to work from now on is going to require an awful lot of public cooperation. And to get cooperation, we need people to feel that their experiences have been accounted for insofar as it's possible. So I think, if we're going to depend on that going forward, and it seems we are, then we should kind of try and tell people what we've done to learn from their previous experience. Thanks.
Yeah. Thank you.
Okay, any other points? Yeah, seemed to have stunned them into silence. David, and I was going to add something afterwards as well. Yeah, over to you, David.
It was really just to add some more context to the work that we're driving with Claire and the work streams. We do know that as a CCG, we are moving into a space where we are going to be expected to merge by 2022, and that is the kind of direction of travel, and the development of our ICP is integral to that journey as well. So the parallel planning, parallel setting up of services that will deliver care for people in the local areas is really important. I think the good thing that the CCG and the strong position we're in is we have really strong localities, we have really strong primary care development and areas where we can connect our colleagues in the rest of the system to ensure that each place has a specific flavour to it. And I know that we've always been keen, especially through the delivery board, in maintaining our local flavours where needed, because the differences of need are different in different areas, and we know that culturally it's important to keep that driven as part of the process of design going into what will be a merged CCG plus an ICP coming out the back of it. I think that the next step that we're working on as well is how the providers collaborate differently, and that was a really good example using patient engagement, but a multitude of other areas that providers will need to think differently in terms of the next step coming into that journey. So it really is a action for all. It's not just an action for the CCG to manage how it develops going forward, but one that will affect our staff, one that will affect where we focus our priorities over the next year, and how we invest the right time and effort into it. And we'll start bringing back that information more and more throughout the months coming forward. We now are talking about where we target our organisational resource, and I think that's going to be the key stepping stone into the next stages of the ICP being really, really effective. Okay.
And I think the only thing I'd add to that, David, would just be that, and Claire and I haven't had a chance yet to reflect properly on the ICAG from Tuesday, and some of you were present. Trevor, have you got your hand up? I'll come up to you in a second. But I think that what there clearly was a determination for clinicians and professionals to actually shape and drive the transformational energy and input into decision making and to the ICP board. So I think there has been a reframing of it, and we are going to follow that up with, I think we're hoping 2 ICAG meetings by the end of December, and we're going to certainly focus on elderly, frail, but more on the metrics of what we're actually going to be achieving rather than just the aspirations. So much more practically orientated, and that's coming up. But Trevor, you were there for that? Well, yeah, I don't know if you've got any reflections.
Sorry, I didn't make the ICAG meeting on Tuesday. For some reason, I didn't get an invitation. So maybe if we could check them on the list, that'd be great. But I think that the paper's a really good overview of what's happened, and it's good to see things are getting going again. And I suppose it's really just what I was saying earlier. My concern is sort of the risk of things getting very busy again over the winter, and whether we will be able to keep this momentum going, because obviously, with COVID, with flu, with winter pressures, that might be a bit of a challenge. So I suppose just a comment on that, and whether how we're going to try and deal with that, maybe.
Yeah, I mean, I think clearly that is a challenge. I think one of the reasons that we've redirected the work in the way that we have to align it to COVID is to make sure that everything we're doing is supporting what we need to do during and in response to COVID. So I would hope that therefore means that what we're doing adds value and is worth people focusing and keeping going during the winter period. I think that was, that was a big part of our thinking, really, was how it was supportive of rather than contradictory to what we need to do during this particular period.
Okay, final point. Is it Rami wants to say something?
Can I come in too before we close this item, Nicholas? Sorry.
Yep. Who's that? Sorry.
Juliet.
Juliet. Sorry. Yeah.
Yeah, sorry, I had problems. I was disconnected. I wanted to come in on the slightly early conversation. That's why I'm not using my background now. So just on the issue of involving people, so absolutely we need to do some work to bring in, to as Claire said, bring together the work that the organisations are doing. There is a group that I chair, and we have met once. We are going to be meeting again and regularly. In the meantime, we've had some involvement in the service evaluation groups, and there have been service users involved in that. So just so people don't think there hasn't been any, there has. We've had a survey on the virtual consultations and user feedback in the virtual hospital group as well. So there has been some of that going on. We need to do more, and we need to kind of build on the work that actually we have all learned over the last few weeks and months. That there's an awful lot, as Alison was saying, that we can do in this rather strange world, and we will do.
Thanks, Juliet. Really important point to bring out. Rami.
Sorry, let me just get. Can you hear me? We need to just have some communication with the COVID and with the return and with the rest, not to get frustration, because patients are getting frustrated. And they're getting frustrated because one message says we're going back to normal, and their expectations of normal is to walk through open doors, to be seen face to face, to be able to book appointments face to face, to be seen in hospitals face to face, whereas what they're actually getting is very much more a virtualized approach to care. And I think particularly older patients are finding it very difficult. And as I've been doing flu clinics outdoors, I've actually had as many conversations with my full PPE with people frustrated and not being able to walk through the door, wanting to hand me things or discuss things as anything else. So I think there is a bit of a disconnect here between what's going out and what we're able to provide. And I can't see the answer to it.
So if that's the I'm assuming your context is more on the hospital and outpatient side rather than primary care, because obviously you're all best placed to talk on the primary care side. One of the groups that Avni and I sit on and work on together is how we have been restarting the outpatient activity at the trust and how we're communicating with the public about that. And we did actually have a conversation yesterday precisely on this point. So we have got the communications that obviously GPs are giving to patients at the time that people are being referred, and which is available on the hospital website. But we also talked about the fact that actually people aren't hearing things over a period of time, and actually we need to do some more work on those communications to address some of the concerns that people are coming with. So Avni, I don't know if you wanted to just add to that.
And absolutely, and also added to that as well is what we did say, what we're going to link in is giving some supporting information as well for patients, especially where they're anxious, and how they can access some of the services that are available in the community through HPFT. So we are revising the communications as of our discussion yesterday as well. But the comms should be available in terms of from general practice, but also from the hospital side as well, whether that comes through any route.
So can I just quickly on that to say that there was a patient information leaflet that actually we produced with the trust that I think, I mean, Rami, you're right in terms of how, the balance of the message, but actually everybody, all practices should have access to that patient information leaflet. And if you don't know it, then we'll send it through again. It's on websites, and obviously it does need updating. But if you haven't seen anything, then let me know.
Karina, did you want to come in?
So I was just wondering whether is there any point in involving patient participation groups with dispersing the message, because yes, I couldn't agree more with Rami. There's a lot of confusion out there, and there is quite a gap between what we deliver and people's expectations.
That's a valid point, Karina. I think with the revision that we are now doing with James in the trust and with Louise Manders, we will make sure that goes via the PPI groups as well and how we use them.
Yeah, and we have covered this off at the TPI committee and at the patient network meeting as well, actually. So that is absolutely, you're right, Corinne, a really good way to get messages out too. But I think it's a classic case of just because you produce something or you have a conversation doesn't mean you're done. We need to continue to get those messages out and use the PPGs.
So I think quite a lot of this will sort of also be covered, Julia, in the item 18 comms and engagement report. So I'm going to sort of draw that discussion to a close now. But thank you very much, Claire, for coming along. And it's very much all of our business now. It is our ICP, of which Herts Valleys and the commissioners and the practices are very much part. But thank you very much for all your hard work and organisational behind the scenes. Okay, thank you very much.
Bye.
Okay, now we're on to item 13, the winter plan, and very much welcoming Tracy Brown and Avni that are going to talk to this. This is an item for assurance and information. So over to the two of you. Thank you.
Thanks, Nicholas. I'll kick off and then I'll hand over to Avni. So the winter plan sets out the winter planning arrangements across the system. We do it every year, and we develop this in partnership with the system partners. So we look at lessons learned from the previous year and build on those. Some of those lessons learned then become business as usual services as the year rolls on. We've also learned from COVID and recovery, so picking up on Trevor's point in the previous presentation. So we have looked at what recovery looks like and how we can map that into the winter plan. The plan is divided into service areas and details the service delivery and the capacity planning. And it also details the services for emission avoidance and for discharge. And there's a section identifying risks and mitigations. So we recognise it's an evolving document and it dovetails into other pieces of work. In particular, it dovetails into the winter commissioning plan, which I think Abby's going to talk more about, and that's within section 9, sets out the high-level information around what we may do to commission additional capacity in winter, as well as the ICP discharge recovery plan and the ICP D2A and urgent care evaluation. So all of those things will move into that winter plan as we move it forward. In previous years, the plan hasn't been ready till about sort of November time, so we've been ahead of the game this year for obvious reasons, sort of managing COVID and recovery. I'll stop there and hand over to Avni.
So I think it's fair to say, as Tracy has put out, that this year is slightly unusual because we're not just planning for a normal winter, but also with any sort of surges in peak 2 with COVID as well. I know we've had initial discussions in terms of some of the additional services that we need to stand up, put in place for this winter, especially learning from our respiratory hubs, the work that we need to do in general practice in terms of increasing capacity. But also what you'll hear from the next agenda item as well is our community services as well and the work that's happening there. But the additional capacity as well that we are having to put in with regard to crisis management, whether that's for mental health in terms of A&E diversion hub or whether that's a rapid response in the community as well. What we have done this year as well is rather than looking at it in terms of spot purchasing community beds, like we're learning from the previous year, we are pre-planning and moving ahead to actually say that there are certain pathways that we want to continue commissioning, which is in particular the non-weight bearing pathway, but also working hand in hand with the county council colleagues around the D2A, as Tracy mentioned. There are a number of beds that have been purchased through the whole COVID period, but also reviewed during that time as well, whether to step them down and how quickly they can be stepped up or stepped down, which will support our winter for this year as well. We are at the moment in discussions to actually look at capacity with regard to nursing home capacity, because at present we are absolutely fortunate with the residential capacity, but where we are lacking at present, even though with the stark number of care home beds that we have in Herts Valley, we are at the moment not able to purchase the nursing capacity, which is what we're looking at. What other innovative ways could we look at to support the winter this year as well? What I think the important thing to note, though, is much as through the COVID and learning as well is we have had really good input from our community provider, CLCH. With the 97 beds that we have had throughout the whole COVID time as well is the capacity that they have put in and the mantra, which is very much of patients getting care at home, is absolutely embedded across that whole organization. Through that, I think what we're really proud to see as well is that there has been always capacity in the community bed bases throughout the whole period of COVID, but also even now, whereas compared to previous years, we were always struggling with capacity in the community beds. So I think I wouldn't say much. I'm sure Sarah and Karina will touch on this later as well. But this really impacts on our winter capacity, which in previous years that I've been around here, we have struggled to actually have in this area. What it actually also gives as well is it gives the board a plethora of services, and actually across the board, whether that's mental health, children's activity, as well as looking at it from planned care as well. So I'm hoping this provides enough information in terms of what we are doing in this, in terms of increasing the capacity, but also ensuring that the system resilience team actually have the ownership of actually monitoring the impact of this on a monthly basis through the SRG group as well, which will then feed into the evaluations which will be presented at a later stage to actually inform what the future planning needs to be for ongoing basis. Happy to take any questions.
Okay, who wants to kick off? Yeah, Stuart.
Where this should come into to questioning, but it doesn't fit in any of the other papers. So whilst we're talking about the winter, then we talked about a couple of weeks ago at commissioning exec about the hub for Hertsmere. So there's an urgency now for this to be in place as COVID starts to increase. So can you give an update on what's happening with regard to this, please, Avni?
I think Kate's got a hand up first. Kate, do you want to go?
Thanks, Stuart. We had we've had quite good progress really. So we've managed to get Alum Hall, which is right by the station in Elstree, to agree to have a mobile unit sited in their car park. It's a good sized car park. It's quite central for Hertsmere practices. We did a site visit to Alum Hall yesterday. And they were very welcoming and really trying their very best to try and make sure that they could be as helpful to us as possible. Saying that their groundsman would help us with the maintenance of the vehicle and all sorts of things. So it was a really positive visit. The delay is now going to be really is just trying to get the mobile unit on site. We've got a company who are designing it from scratch. So that is how we want it to be. It's going to be a good unit, but it's going to take about 4 to 5 weeks before before it's up and running, because it takes about 3 or 4 weeks to get it on site, and then we've got to equip it, which again is going to take about another week. But we are motoring, and in fact, we're going back to them to try and see if we can push them on their timescales.
Avni, do you want to come back on that? Anything else?
Yeah, so in addition to that, obviously, we will be, as we've heard from both of what Jane and David said as well, is in terms of our COVID peak, we are looking at it in terms of around mid-third week of October. So what we are looking to do is to stand up the activity in Stuart, in St. Albans as well, at least as latest as to the third week of October, so that we can start actually mobilizing more activity and capacity in the community as well. But at the moment, it looks like both our current hubs that are running in Dacorum and Watford have got the capacity to work on it. In addition, obviously, we are working with the children's provider as well, HCT as well, and hence, which you will reflect in the winter plan, there is about enhancement of the chorus service as well, because we do understand that at the moment, there is a rise in COVID cases, but a lot in children's services. So what we need to actually make sure is that we've got enough capacity in there, and they are integrated with the adult pathway as well that we've got in the respiratory hubs. So we are working through that, Stuart, and there will be a regular update at commissioning exec in terms of progress on all the hubs as well.
Thank you.
Yeah. Can I just come in with one point, really, which was just a point about the resilience of our workforce across the system going into winter. I think, people have had an incredibly tough 6 months, and yet they've actually got to dust themselves up and actually now go into what maybe, I think, as we heard earlier, a very sustained peak rather than actually a short, sharp shock. That's got, so I just wondered what you could say, or in terms of the discussions that have been had in terms of the winter plan.
So absolutely. absolutely. So all of these plans that we put in place, one of the things that Rashina, who is on the call as well, who's been orchestrating actually the whole plan in terms of the commissioning bit, is to actually work with the providers to actually look at the deliverability as well. Because there is no point actually agreeing into a commissioning plan if there is no workforce or the infrastructure to deliver it. Providers have given us assurance, and that has been picked up through their regular catch-up meetings as well, to actually look at how they are enhancing that workforce and do they actually have the workforce ready for October to start. We have got assurance from the main providers, which is CLCH and HPFT, where they are sending up a large number of services, as you can see from the plan, to say that they do have the workforce and they've already got plans in place of who they're bringing in and how they are reutilizing some of their other workforce as well. Bearing in mind that this time round, the planned care activities still continue. So we are not redeploying any of our existing workforce necessarily onto this, but what we have got is a range of bank and locum agency staff who have been brought in to provide this support. So we feel pretty confident that they can actually deliver a lot of it at present.
And just on that theme, Avni, in terms of primary care, I think one of the things that people have heard me talk about outside the board meetings has been the wide variation in primary care network allied professionals. So we have some incredible examples across our patch. We have also those that have actually really hardly started. And I think that, is something that we probably do need to sort of address in the future months.
Absolutely. And I think there's a real opportunity of actually having more an integrated workforce in primary care that can be enhanced and that can be used as well. Together with that, obviously, one of the key things that has come out with all of this workforce is actually having the ability, while we are in COVID, is to have the testing, swabbing capacity as well, because we will not have the workforce if they're not able to be tested. One of the things that we have taken a pragmatic decision across Hertfordshire is to set up our own testing capacity, which has been provided by CLCH, as well as HCT has been stood up as well as of today, as of tomorrow, Friday. So we will have both capacities running actually for our key workforce as well. So it's really vital that we actually get our workforce tested so that they can provide the care that's really required for frontline staff.
Okay. Alison, you've put your comment on, but did you want to expand on it?
No, sorry, it was to the earlier one about PPPs.
Okay, fine.
No worries.
Okay, fine.
Sorry,
okay,
no worries.
not to lose any comments. Okay, anybody else wants to speak? Because I just want to thank, Tracy, Avni, and all of the teams in this. This is a mammoth piece of work, and of course, it will probably go through many iterations as we experience the autumn and winter. Okay, thank you very much. Sorry, somebody wants to just add something. Sorry.
Yeah, can I pick up on Alison's point around the patient and public involvement from the previous presentation? So with the D2A evaluation that we're doing, we are seeking comments from patients that have gone through that process. So that we're doing that jointly with HCC. So there will be some data that comes back from that, qualitative and quantitative. And our intention is that we will wrap that into the CHC paper that goes to quality committee, so that the board are cited on those themes and those comments that come through. I just thought it was worth mentioning that.
Thanks, Tracy. Very, very helpful.
And maybe Tracy, maybe you could send that to the PPI committee as well. I think they'd love to hear about that. Thank you.
Okay, thank you very much. Naomi has been a substantial part of our work over the last year. We're going to talk about that at the AGM as well. But item 14, is Sarah on the call? Yeah. Okay. So this is actually an attachment it's an update, but attachment for approval. So Karina, Sarah, who's going to kick off?
Sarah will give the update. Sarah. You're mute, Sarah.
Sorry, I'm muted. Is someone able to put the presentation up on the screen? No? Okay, so we're...
You might be testing the boundaries of our internet if you do that.
So I'm not going to...
Sarah, we've sent the paper out. So
okay, I'm not going to go through the paper. I'm going to go through the presentation. So if people can look at that on their screens, I will go through that. Thank you. Okay, so Karina and I have been leading on adult community services for the last 18 months. Today, we'd like to give an update on their progress over the last year. I mean, many of you will know that the CCG went out to procurement for adult community services over 18 months ago, and CLCH services commenced in October 2019, so they have been running for nearly a year. So if we look at the next slide, which is about the current changes to the historic service delivery. So services were mobilised across all 17 service lines in October 2019. In March 2020, when COVID hit, CLCH quickly reorganised themselves to deliver 3 core areas, and these were the discharge to assess model, which was in line with the national COVID NHSE guidance. It was delivered in partnership with West Herts Trust and Hertfordshire County Council. It was very, very successful, and good relationships were formed through those three organisations. So it was a very good model to deliver. They also continued to provide community inpatient beds to the system, and they provided community nursing, which was split into red and blue teams. Red for the suspected possible COVID patients, and the blue teams for the housebound, vulnerable and shielded patients. They also, above their contract, delivered additional services. They provided swabbing to health and social care staff at Harpenden. They supported care homes and hospices with PPE and infection control measures. And I know the hospices really welcomed this. They welcomed a strong NHS provider to give them the advice and guidance through COVID, and that was very welcomed, and fabulous relationships have been made there. They also provided virtual solutions for their services, and they also were part of the COVID virtual hospital provided by West Herts. So if we go to the next slide on restoration of services, every 2 weeks, CLCH and CCG have been meeting to look at the restoration of all service lines post-COVID, and also we're keeping track of their planned transformation of services. CLCH have given us detailed capacity and demand trackers to give assurance on the clearing of their backlogs into their individual services, and we monitor this every 2 weeks. Now, we know there are longer waiting times than average in services like podiatry and neuro rehab, and CLCH have come up with proposals to bring down the waiting times, i.e. by putting in additional staffing or a different way of delivering the service. We're also putting in virtual proposals for services like cardiac rehab and neuro rehab to bring down these wait times, and also to ensure patient safety. Next slide is around transformation. There is a list of transformation this year in the contract that CLCH were to deliver. And although we've had COVID, some of these dates might have slipped, but all of the planned transformation in the contract has taken place within year 1. And these are things like rapid response, GP step-up beds, multidisciplinary case team meetings, 24-hour specialist palliative care helpline, enhanced heart failure services. Some of these services have taken learning from COVID, and we've now moved to a more virtual offer. The frailty service will now assess patients in their own homes with virtual consultations with the geriatrician, instead of vulnerable patients being brought into clinics. We've got further transformation to be delivered in year 2, and we're looking at future modelling of bed-based units, IV diuretics in heart failure, where patients can come into a community clinic or have that delivered in their home rather than staying in a bed in the acute trust, and also the IV antibiotic pathway. CLCH have undertaken a massive estates transformation. As part of the contract, Harpenden Memorial Hospital, Langley House and Potters Bar were transferred to CLCH. Some of these properties were not fit for purpose to deliver clinical services. CLCH has started an estates transformation programme to ensure that staff have adequate locality bases and clinical services can be delivered safely. If you look at the pictures of how Harpenden Memorial looked 6 months ago and now where we are, you will see that there is a very, very stark difference. I mean, many of you will have been to Harpenden Memorial. CLCH have upgraded the reception area. They've revamped the St Albans and Harpenden nursing team base, so they have a locality base to go to instead of being based at Hemel 1, and they have upgraded the clinic rooms. During COVID, swabbing for health and social care staff was also provided from this location. If we look at Elstree Way has also had extensive work undertaken, turning 4 clinic rooms into 8 clinic rooms. Other stakeholders provide services out of these bases like HCT and all of our other community providers like Communitas for ENT, PML for ultrasound. It's provided an excellent clinical base to provide community services from. CLCH have not only done this estate's transformation, but they have prioritised it out of their capital funding, making Hertfordshire out of their other 11 boroughs their complete priority. Elstree Way was also handed over to the GP Federation to provide hot hub services during the first wave of COVID. They've also undertaken upgrades to inpatient rooms at Potters Bar and Langley House to ensure that the rooms are infection control compliant, and also have been upgraded to have ensuite bathrooms to the rooms. Workforce continues to be a challenge, as it is everywhere. They're carrying a 19% vacancy rate, but posts are backfilled with a rate of 85% from bank and agency staff. Areas of challenge are Band 5 nurses and inpatient units, and in September they had a virtual recruitment day. If we look at rapid response, which was rolled out in July, they will have full recruitment by December, which is a great achievement. So if we look at delivery above and beyond contract, this final slide shows some of the initiatives that CLCH have delivered during COVID above and beyond their contract. I think we have to say that CLCH has done a tremendous amount of work during the first year of their contract, and despite COVID, have restored service and delivered the transformation that was agreed with the CCG at the outset of the contract. I don't know if Karina wants to say anything else, but we can take questions.
Yes, just a very few points. Sarah sounded very positive and almost like she's praising CLCH, which is, I promise you, on our 2 weekly meeting, that's not what she does on our 2 weekly meeting with them. She's been very good at calling them to account. You know, it has stayed with me for a very long time what the comment of Anne Radmore when she came to see us in Harts Valley, when she said that, you know, it's all good and positive to get a new community provider, but you shouldn't really take your foot off the pedal, and you should continue to monitor them closely and work with them closely so they can deliver a good service. So, yeah, I can confirm very much the fact that this has been an organization that has proved to be very receptive, has proven to be very cooperative, very responsive. So I do have a lot of positive things to say about them. I think where we're lacking, and I think it is important that the board knows that, is our work with CLCH promoting integration. I must say I've been really disappointed to see that many of my colleagues in general practice are not aware of the services that CLCH are offering, despite us going to numerous meetings and, you know, trying to promote it to the best of our abilities. I think a lot is to do with the fact that we receive so much information nowadays on a daily basis that sometimes it's very hard to retain what's being fired at us. For that purpose, and because we do not want this excellent work to go wasted, for that purpose, we're going to design a program where I'm really going to go from locality to locality meeting, and we're going to tell them it's going to be personalized for each locality, you know, about their premises, about their services, where they are, how to be accessed, what do they deliver. You know, because that will help CLCH as much as the general practice. So we're going to try and do that over the next month or so, and pretty much encourage general practice and the PCN to work with this good community provider. We're working very much on supporting a good relationship between the community provider and the acute hospital. As you've heard Sarah mentioning, they did deliver, CLCH did deliver part of the virtual hospital project, and they did work together. There are tensions there. In actual fact, I've got a meeting tomorrow night with, no, it's night here in Greece, tomorrow afternoon with the West Herts hospital consultants, just to try and see what is the best way to work together with the community providers and deliver an excellent service. I don't know if I've missed anything else, Sarah, but I'm very happy.
I'm quite keen to take questions. Stuart's very much there, so Stuart.
Question really, having been part of the procurement team many moons ago, obviously we were hugely impressed with them as an organisation, otherwise they wouldn't have got the contract. But when I look at what they've delivered to us over the last almost year, particularly delivery above and beyond the contract, I think they are a tremendous organisation, a huge benefit to us as a CCG. They've helped us out in times of difficulty the last 6 months, without question. Everything we've asked of them, I believe they've delivered. And I think, you know, we expect that of any of our providers, to be quite honest with you. Not all of them deliver at that level, as we know. And I think recognition, I know it's just a year, but a recognition from either the chair or our managing director to them, a letter saying, you know, this is the first year, da-di-da, but a real thank you, because we're going to expect a lot more for them over the next year or two. But it's been a real superb contract, major decision, but it's helped us tremendously as a CCG, and I would like to let them be recognised for that.
Okay, points taken. Rami.
Let me unmute myself. I think the one thing that they have changed, and one thing that we've battled with a previous provider for decades, is the can-do mentality. And I think that's something we need to go out to general practice, to our colleagues and the rest. They have been, basically, it's been a war of attrition of we can't do, to the point that a lot of our colleagues have decided just not to bother anymore. And suddenly we are getting a can do. And I think it's a mindset as much as what they do, which is that when you get to them, even when there is a problem, they try to work with you towards a solution rather than give it to someone else. We reject the referral, we send it back. And that's really what we should work on. And I think what Karina is saying about going out to express what they're doing would be really useful. I would actually suggest some case exemplars in all the areas. You know, if you look at the referral thing, it's got masses of areas that a lot of my colleagues are not aware that they do. Most of the times when they say, where do I send this? CLCH. Where do I send this? CLCH. I'm getting fed up with this.
Okay, Rami, point where Trevor?
Yeah, I mean, I'd just echo all the other comments and say I think they are providing a very good service. I suppose the one area as a GP and decorum that I've noticed maybe not quite as slick as it used to be is the rapid response, where we had the holistic team locally, which would literally take anything. And certainly this week I've spent a little bit of time on the phone, probably being sent round in a slight circle. So that would be one area I could see, certainly from the decorum point of view, could be improved. My other question was, just very briefly, is I suppose the workforce issue, because the deterioration the increasing vacancy rate from I can't remember when, September till now, seems to have gone up. And I mean, I appreciate it's difficult everywhere, but do we know why it's sort of got worse? Because as you say, this is a good organisation. I know from the initial work we did recruiting them that you know, they have good education, they have good workforce planning. So I'm just wondering why it's deteriorated. I don't know if we can answer that.
Trevor, I'll answer first the situation in the quorum. I think there is still a little bit of confusion with regards to the difference in service specification between what the Quorum Holistic Healthcare team used to offer and what Rapid Response is being commissioned to offer. This is to emphasize the point that I'd made earlier, that there is quite a bit of unclarity amongst GPs on the differences in the service. And it looks like it's amongst board GPs as well. So with regards to the vacancies, I'm going to let Sarah comment on answer.
So in terms of the vacancies, if you look at planned care, it has deteriorated, but this is because Rapid Response came on board in July, and a lot of those posts are really attractive to staff, so they have moved across, which has left them with a bit of a gap in planned care. But if you look at where they were, with 75% vacancy rate that came over with specialist services, you know, where those services were across county and those staff members stayed with HCT, they have really been able to manage to fill those with staff that have given extra hours from Hillingdon, etc. So they have really, you know, with what they came across with and where their position is at now, I think that it is quite a good position to be starting off with.
Okay, okay, David, Avni, I wasn't sure. Avni first, is it? Yeah.
Yeah, sorry, just to add to that, and I think the other bit, so I think it's the way we have written it in the paper, if anything else, because the model that CLCH has put in is actually heavy staffing resource. So actually, their vacancy rate compared to what was inherited is actually it's quite small, if anything else. Our main issue, as was highlighted even at that time, was the specialist services. The services that they have put in place, especially with the planned care, the CTU at St. Albans, which is the treatment unit, and the rapid response actually has got a heavy whole-time equivalent, which is what we required to actually meet the demands that we needed in it, compared to what we had inherited as well. So that's where the gap is. So I think when you're comparing like for like from October to what they inherited, to what they have, you'll always see a decrease, but actually against their plan, they're doing pretty well, and through all the services up and with. The bedded units is one place in terms of Band 5 that they absolutely acknowledge that they need to work through even better. So we said they are doing.
Okay, fine. And I think it was David.
So I think this is such a timely paper. If you go back to when we were about to go and even make the decision of commissioning, the system thought we were crazy. They said, you know, why would you just, you know, rock the apple cart? Why would you, when everybody's working really well? And as a CCG at the time, we really understood things weren't working well. We could see the data, we could do everything that commissioners should be doing in terms of making a bold move. And we did that through the procurement. We were challenged, and we've now delivered on this service being operationalised. And I think it's testament to the work that Sarah and team and Karina have done in terms of continuing to drive them, because as much as they are a responsive provider, you have to have some of that grit in there to make sure that they're actually doing it, and a little bit of applied pressure. And I think the team have been fantastic in having a really robust delivery plan that meets with the provider on a weekly basis and holds them to account. But at the same time, we have a provider that talks a different language to our previous provider. I'm sorry, it talks in a different way and responds in a different business approach. And if you look at the pictures that Sarah's presented of Harpenden Memorial, that's investment above and beyond what we invest in them, because they know that Hertfordshire is a place worth delivering the best care from. So you can see how those buildings have changed. And I did tours of those buildings before, and you know, they'd been left to disrepair, and that was inappropriate anyway for NHS buildings. So now they're back to where they need to be. There's still work to be done, and there's still drive that we need to put into the system. But you know, I think the team have been fantastic on this, and it's a perfect example of commissioning and managing a contract and mobilising a service to be ready. So just a big thanks to the team, really. Avni and your team, you've been fantastic delivering this.
Yeah, can I just echo that, David? I think that the team have been tremendous. I think that we also have to thank the work up to the procurement, you know, the involvement of patients, the attention to detail on the spec. The reason why we now have teams with more than one person is specialist teams within CLCH is because of the attention to detail and a responsive provider. So all of that augurs so well, and I have every confidence that our team will continue to ensure that they continue to deliver at the very highest level. We know there are going to be blips and things up and down, but to have achieved what they have within COVID is truly remarkable, and I absolutely echo Stuart's point that we should be we will send a letter to them and to their board chair Angela. So there we are. Thank you very much. Now we are asked to approve this. This is for approval, so do I have everybody's approval, please? Thank you. Okay, that's carried. Okay, moving on now. Thank you very much, Sarah, for presenting, and Karina for coming from Greece. There we are. What more can we say? Dedication to duty. Okay, moving on to the annual health and safety audit. I'm definitely not going to ask Amanda. I know it's a tremendously detailed piece of work, but this is for discussion and assurance. I'm going to take the report as read and ask Amanda if there's any particular issues that she would like to highlight.
I don't think there are perhaps any particular issues. I mean, the internal audit, just briefly, the internal audit picked up a couple of bits and pieces which were just really COVID delays on things like, you know, there was a policy and a management audit which had been delayed because of the standing down of business as usual with COVID. I think just the key thing, we're substantially compliant. That's the same as 2 years ago when we had the last external audit. Just the key weakness, I think, for us to think about is the dissemination of information to staff on the shop floor. So corporately, we're absolutely fine, more or less, but it's about making sure line managers take the responsibility for getting all the information, embedding the policies, all that kind of thing down to the kind of grassroots level. So priorities going forward, the implementation of a health and management safety system is going to be actually key to actually resolving most of the issues which came up as part of the external audit. But that's all I would pick out.
Thank you. Thank you. Questions from the board? David, do you have any comments just on the point that Amanda's just made in terms of dissemination of information? I know you've been working really hard with the rest of the team in terms of the staff updates, and perhaps that's a way that we can continue to improve that.
So I think there's always more you can do in terms of communicating with staff and giving them updates. And, you know, we've just talked about making sure that things are palatable and readable for individuals. And then even we talked just now about GPs being fed information about CRCH and not knowing. So it's really sometimes assuring yourself that people have received and understood. And there might be some things that we do throughout the staff briefings rather than written. And we're just trying to get balance right.
Okay, thank you. Any other points or questions? So it's not actually for approval, but thank you very much, Amanda, for that and for the work of you and your team. Okay, thank you. Now moving on to the joint quality and performance report. Once again, I'm going to take that as read. Claire, are any particular areas that you wanted to highlight?
I think the main thing to say is that we did continue monitoring quality and performance, even though the contract meetings were stood down during COVID. We did look at other things such as SIs and complaints to make sure that we had a feel for what was going on. You've got the report here. The data is slightly out of date. I have got a slightly better and more up-to-date picture to give you. For June, if you go to the 0.3 on the 62-day wait, we are now at 87.2%, and that's under the cancer heading. So there is a slightly improving picture. And also for the 31-day subsequent surgery, that's up at 100%. It's not all rosy, but we are seeing some improvements. I think our biggest challenge is still our RTT and our waiting list. There's been such a lot of work on the waiting list and the backlog catch up from standing services down in COVID. As you're aware, we are working towards the third stage of recovery at the moment. One of the things we're working on quite hard is their clinical audit reviews. I'm pleased to say that we have got a process for this, and it has been agreed across the ICS actually that we've got a process, and West Herts are working on that. We are supporting them in one aspect, and that's to do with the cancer waits, where the first appointment is at West Herts Hospital and then the patient goes on to a tertiary provider. There is some delay within that, and they have asked for our support to see if we can unpick some of that delay, which we are taking up. Kate is investigating how we can support that piece of work. The only other thing to say is that actually West Herts are looking at their 52 waiters reviews at week 48. This does give them a little time to enact some change or identify any high risk areas that patients that need to be looked at earlier. This work is slow and we have got a substantial backlog, but it is being worked through, and like I said, we are monitoring very quite closely. The only other area I think is Royal Free London, which I'm sure you're aware of, that they have got, I think it's 250 patients, Herts Valley's patients, waiting over 52 weeks. I'm sure Avni will correct me in a minute if I'm wrong. Their plan is being closely monitored by us, and we are in liaison with NCL, who manage the contract. NHSE EI are also involved in this work with them and scrutinising their plan to resolve this issue. The other bit I would just like to touch on is the quality aspects, and I think the biggest thing to highlight here is the improvement with HPFT and their SI backlog position. At one point, I think we were up to 60 SIs in backlog. They have completely cleared their backlog now, which is a great position for them to be in. And as a CCG, we're now working through those and ensuring that that learning that they've identified is being actioned. But other than that, I will take questions on the performance and quality report. It is a joint report and it will continue to be a joint report. We feel it has worked very well during COVID to be joint, and our next steps for stepping up more in-depth quality monitoring and assurance with the providers is very much in a partnership way, and to look at the impact of performance on the quality and the patient experience, which is a very valuable relationship, and to have discussed at the same meeting.
Thank you, Claire. Questions or points?
Just seen Jill put one.
Oh, right, Jill.
Page 220.
Yeah.
220. Where are we? 220. There's been no harm to patient. Is this in review? Let me just scroll back up to 220. Is this the clinical harm reviews? Part of the process for clinical, yes, it is. So part of the clinical harm reviews, Jill, is that if a patient hits the level of harm that would trigger an SI, we would get an SI, a serious incident report through, and that does a real deep dive into exactly what happened and the processes and anything that should have been done differently. We have had no SIs. We have also been assured that the clinical harm reviews are being audited, and any of those low harm areas they're being looked at for learning. We haven't seen that, and that is one area that we have asked to have a review of, but we haven't had any SIs.
Yeah, I think it's very reassuring that there are no SIs, but I think that from a patient perspective, any amount of harm is of concern to them, and there's also a lot of anxiety about the weights, and I think that we shouldn't underplay that too much, that's all.
I completely agree, which is why we're wanting to actually have sight on the audits they've done internally.
Thank you.
Have you got Nicholas?
Well, it looks like we've lost Nicholas. Trevor, you had your hand up.
Yeah, no, just while Nicholas is regrouping. Yeah, just I think it's a very comprehensive report, and positive to see that we're getting data back now. Now that things are calming down a little bit. Obviously, they're not up to where we would normally expect, but I think the recovery is being well planned. And we're keeping a close eye on it. So I think that's positive. Again, I'm being a bit negative today, but obviously it does depend very much on what's going to happen in the next sort of 3 or 4 months into how we see these numbers go. But it will be what it will be, and I think the team are doing very well to keep a close eye on things.
Thank you.
Okay, Alison, sorry, I'm back on.
Hi, Claire. I wonder if you can fill me in a little bit on the broader picture about the quality of information coming out of the Royal Free. You know, it's been a very long saga trying to get any information at times, and I know it's been raised in the other part of the county about the lack of information, the accuracy of information. It's really hard to know how to kind of help or encourage or probe if we don't actually know what's going on there. I'm just wondering if you feel it's getting better.
I would say our relationship with the commissioners at NCL is better. So we are getting more information from the commissioners, and we are around the table for the meetings they do have. Our relationships in regard to SIs is still very strong, and we get an awful lot of information on those most serious of events. I think there's a way to go, and I think it's just maybe reflective of where the Royal Free is at managing the whole process. I don't think we're in a position where, as a CCG, we're further away than any other CCG. I just think they have got a big action plan to sort out on many aspects, not just the RTT, and we're doing what we can do. We are attending all the meetings and dialing in where we possibly can. I don't know if that answers your question. It is probably one of my worry lists as well. So whatever does happen, we will be still pushing to get more information from them. The quality of information that comes out, I think, in regard to things like SIs and the other patient stuff is okay. It is the data, and we do seem to have blips when they come through. I don't think I can answer that question because I think we have to wait until the plans are enacted to see whether it does have an impact and understand that that data they're presenting us is real and it is changing.
Okay, it's just that it is being identified as a kind of an intransigent problem.
It is.
And it's so easy once it becomes an intransigent problem to say, well, that's just the Royal Free. We can't get data out of them. And
not saying that.
If even patients are noticing, no, I know you're not saying it, but I'm just saying that's the perception. I'm just wondering, yeah, it is a partial answer. It just seems to be a long-term problem, and I'm wondering if there's any other way we can explore to get more traction.
I mean, Alison, I think you're so right to highlight this. This isn't only an issue. This is particularly an issue for patients. You know, ultimately, this is about patient experience and patient care, but it's also a particular issue for the GPs and the practices that are actually having to deal with this. So when we talk about the 250, I can't remember the exact figures, and that involves a lot of time from the GPs in those practices, most of which are nearly all of them are in my own locality, particularly Potters Bar and Boreham Wood, and it is noticeable in a practice that, you know, for those that practices like mine that face two ways, there is a huge difference, I think, in the ability of the two trusts to connect with us. So I think this is something we need to do further work on.
And you're absolutely right. I think it's my pausing that's not helpful. NHSE and I are also on this, and I think what we might need to do is give a little bit more of that detailed work that we're doing that will maybe give you the assurance that we are trying and we're not just saying, oh, it's what it is.
Sure. Karina?
It's great.
All right, sorry, I don't want to sound presumptuous, but from personal experience, what tends to help in such cases like this tends to be the involvement of a clinical lead or a GP clinician.
Yeah, before you go any further, Kate, we really do have a very good clinical lead, but Kate, do you want to just say?
So Sai Ramanathan is the clinical lead for Barnet and Chase, and he is absolutely on their case. And myself and Sai meet up regularly. In fact, we've got a meeting, I think it's planned for next week, Nicholas, to literally just focus on the issues that are going on at Barnet Hospital.
Yeah, no.
This has been tackled at ICS level as well, and there's actually weekly performance meeting at ICS CCG level that are happening, and the trust has actually just employed an RTT director, which I think is this month, Avni. They've come into post, so they are putting some action in there as well.
Okay, Okay. I'm just about conscious of time. Is there any other important points before we move on? I'm not getting any takers on that. So thank you very much, Claire, for the detail and for the clarity, actually. So that really appreciated. Now on to Elka and the finance report, which is also for assurance. Elka.
Thank you, Nicholas. I'm taking that the report as read, so I will just talk about some of the specific issues I might want to highlight to committee. We reported at month 4 a deficit of 720k, and that under the regime that we are working to with NHS England will be topped up, and in fact was topped up during month 5 to get us to a break-even position. So that's the financial regime we're operating under in the first 6 months of the year. NHS England do want us to justify the reasons for variances that we are reporting, and we have done that. It is predominantly due to COVID expenditure. So just to highlight a couple of the variances, in community services, we are seeing an overspend for the first time, and that is indicative of some of the service providers beginning to ramp up their ability to deliver services, and therefore overspending in some areas, not all, but in some. In continuing care, which is probably our largest overspend, we're seeing some quite significant increases in unit costs for care packages. So these are patients that have been going into care packages since the 1st of April, whose care needs are greater and more expensive than they were pre-COVID. Other program, that program budget areas where our hospital discharge program costs are coded to. So this is the program that is funded from national funds. We are reimbursed for that if we are overspent overall, to aid the discharge flows out of acute hospitals. We manage that on behalf of Hertfordshire. So that expenditure includes expenditure incurred by the council and incurred by Eastern North Herts CCG. And that is reimbursed by NHS England. That scheme changes. It changed from the 1st of September, and we'll be reporting that to board in due course. Mental health, we are anticipating to meet our mental health investment standard, and the spend profile is towards the sort of latter half of the year. And we are reasonably content at the moment that the plans for investing into services will meet the standard requirement. Another overspend area is primary care. Again, this is largely due to COVID, either for infection control measures or for opening practices during bank holiday weekends, which of course is when the COVID was at its peak. If there are any sort of specific questions, I'm very happy to answer them, but I think this is probably a reasonable quick run through of the key reason for the variances we are reporting at month 4.
Thank you. Kate.
How are we sitting in terms of our CCG versus our neighbouring CCGs in that respect, Elka, or don't we have that information?
We do. The difficulty is COVID expenditure. And in fact, we pushed back quite strongly to any attempts at benchmarking by region, because we manage the hospital discharge programme transactions on behalf of Hertfordshire. We were the very first benchmark, an immediate outlier. So we've pushed back quite hard and said, please don't make those kinds of comparisons, because it wouldn't be right, it wouldn't give the right picture. I'm not aware that in any other respect that we are in any way sort of an outlier or any different from Eastern North Herts CCG. So there hasn't been any particular reason for concern. So I'm not seeing anything that is particularly different for us than it is for our neighbouring CCG.
Thank you.
Okay. Any other points? Okay. Elka, thank you very much for that. Very, as I said, also very clear. And so we'll continue to obviously monitor this over the following months as per usual. Moving on now to the comms and engagement report. Juliet, I'm going to take it as read, but over to you.
Okay, thank you. Yes, I'll just pick out a few key bits from the report. First of all, and it links to a conversation a little bit earlier, the PPI committee. So the PPI committee has continued to meet. Initially during the first weeks of the pandemic, we had the informal meetings I think we've talked about before. We've since met more formally in effectively the same way we met before, but online and as screen as we're doing here. And I think that's worked well. And actually what's been good is that people who thought that they would struggle some of our patient volunteers who thought that the technology would defeat them have actually mostly, and Alison, I hope you agree, have mostly overcome those obstacles, and that's really positive. We've also continued the wider network and had a really good session recently. I got some really good feedback actually, and David and Avni were both there. I think Tracy Brown, you were at the most recent one too. So again, really good feedback from that. And again, just referencing the conversation earlier, we do send out really quite often, actually, we call it the Hearts Valleys Update, and that is something which goes to all the patient groups and wider network of stakeholders with key information. So I think, and again, we've had good feedback from that, and people have actually said that they have circulated that beyond our network. So I think that's been a really good way to get some messages out. Just want to say a little bit about the COVID stuff. So obviously this has been a major preoccupation for the team for the last 6 months. More recently, the focus has been on testing, and it's been very testing to get the messages across because they're complex and because there's a lot of misinformation out there. So what we were able to do recently, and with help from Nicholas, thank you very much, and working with Eastern North Arts CCG, has pulled together what we've called a Q&A. And this really came out of information that was coming thick and fast, which was that people particularly coinciding with the start of the school year, schools going back, lots of misinformation flying around about what to do if your child isn't well, and go to your GP, ring 111 if there's a runny nose, that kind of thing. So we really wanted to get information out there so that people are really clear about COVID symptoms, what to do, when to isolate, how long for, when to get a test, and so on. And obviously we're also trying to manage expectations around testing, and that hasn't been straightforward, it hasn't been easy, and that will continue to be something of a challenge. And I think also on COVID, we've worked very closely, not just with neighbouring CCGs, but with, in particular, Herts County Council and the districts and boroughs to get the message out around the Play Your Part campaign, which I imagine you've all seen somewhere around Hertfordshire, that we're encouraging people to do the right thing. And again, that's been quite complex because some of the messaging has shifted. So we went from a sort of, use your town centre, it's very friendly, it's very safe, and things have shifted a bit over the last few weeks. Just also wanted to mention flu and some of the complexities around that and winter generally. And I know that was covered off in the previous item to some extent, but just to say that we are starting to promote the flu vaccine for the groups who are eligible. And that's, a key thing. I mean, we do this every year, even more important this year, as we know. My understanding is that take-up so far is good, so that's really positive. The problem that we will have, and the risk is, and I think this was mentioned before in terms of the supply of the vaccine. So much was made a few weeks ago now, the fact that the Department of Health and Social Care had added a very, very large new cohort of patients or members of the public, the 50 to 64-year-olds. And we know that some people in that group were very keen to get the vaccine, were having to kind of hold back and say, actually, you're not a priority group. So whilst we're encouraging people, we're also wanting to actually make sure that the non-priority groups understand that they will not be called for a vaccine, they will not be given a vaccine until probably end of November, December at the earliest. So that's one of those issues we have to contend with. We're also going to be promoting NHS 111 first, which I think was also mentioned earlier. Finally, just to say about staff communications, and it is, and David alluded to this before, that continues to be really important for us. We do a weekly face-to-face, screen-to-screen conversation with all our staff every week, every Tuesday or Wednesday afternoon, and a written update as well, where we send a recording of the session and Q&As as well. So there's a lot of information out there. So we're really working hard to keep people informed and have a conversation with them. And that needs to continue and step up if we need to step it up, and particularly with the office only open for a day, which was a disappointment for a lot of people. Those conversations need to continue, as do the conversation we're having with our staff involvement group, which meet every single month. And I think that's all from me. Very happy, of course, to take any questions.
Thank you for that, Wiz. I mean, I'm really aware of just how detailed and how complex the work is, because you're actually networking with so many other organisations across Hertfordshire and the ICS. So thank you, Juliet, for that in particular. And of course, the Q&As that Juliet mentioned, which I've sort of we've jointly put out in Prague in my name. I mean, so all the preparation of that was enormous, and it is going to be an iterative one. So we can make amendments. So please respond back to Juliet's team if you think there are things that need to be changed or nuances. I think that's really important.
Yes,
we keep it relevant. But I knew that we must have hit some point when I got told via a WhatsApp that we'd made it into the neighbourhood watches of several of the Hertfordshire groups, and I thought, there we are, and that was within 2 days of launch of that document, Juliet. So there we are.
That's really good. It's really good to know. Thank you.
Okay. Any points before? Yeah, Alison. Sorry. You're on mute.
Yeah, sorry. Yeah, I just wanted to add, aside from all that brilliant cooperation with local CCGs in terms of the messaging around COVID, our virtual patient networks, which we're using to address particular themes, hour-long sessions that address particular subjects, are now running across the county, which we're quite pleased about. We're getting some good take-up on those. And it's just another thing that we're trying to do to join up things as well. And what's been really good about it is doing it this way has allowed us to reach audiences that we haven't been able to reach before. We've had people involved that that simply wouldn't normally have had the time or opportunity. So it's been great to see lots of faces from across the county and lots of faces from different demographics, different people. So it's been a really interesting time for broader patient involvement.
Okay, thank you, Alison.
Oh, and I should say that's down to Joy Hale and Heather Aylward, who've been working really, really hard on getting those programs together. Thank you.
Okay, thank you very much. Any other points quickly? No, I'm going to move on then. Thank you very much, Juliet, for all hard work. And we now move on to Katie. Now, I'm definitely not proposing Katie to go through these line by line, but this is for approval. Katie, is there anything that you wanted to highlight in particular on this? There's a lot of red marker pen on the document, so hopefully we can be assured that there isn't anything that we need to sort of just double check on. I'm assuming Katie's there. I can't see Katie waving at me. I think we have. I think we've lost Katie actually. This is actually for approval, so I'm going to need to ask the board, who I'm sure have diligently read line by line, to actually make any comments or views known. Most of this really relates earlier in terms of our constitutional amendments. That's pretty much right, David, isn't it? This pretty much all flows from that.
Yes, Nicholas, that's correct. Yeah.
So unless I haven't got any questions, I'm going to ask. Sorry, somebody's going to come in. Who's that?
Just as chair, I think it looks fine to me. So I mean,
okay, that's helpful just to get some positive affirmation.
It looks fine to me.
Okay, anybody else want to say anything? Okay, so can I ask the board to approve that, please? Okay, thank you very much. Okay, we now move on to committee minutes, which are just for attachments for information. We're not going to discuss them, but you can see those that are there. Lots of virtual work going on, and I think we've all been part of many of these. So I'm going to move on. Finally, is Iram there? Great. Okay, so just a review of how the conflicts of interest were managed in the meeting. Iram, do you have any comments to make?
We didn't have any particular conflicts that we had to manage.
No, I think we made that very clear at the beginning, didn't we? But perhaps more importantly, now going on to the reflection on equality and diversity in relation to the decisions. So I think it would be fair to say that we had quite a challenge today from Thelma, and I think that's something that we're going to go away and reflect on. But is there anybody else that would like to make a comment on that? Unfortunately, Thelma's had to leave us early. Okay.
I would agree, Nicholas. I think it's a reminder to the board that we need to debate this more often and have a more of a conversation in this space about how we are working with some of those challenges and what we're doing about fixing them and moving forward as an organisation. So it's creating the space for it, I think, is what Thelma wanted to do. Yeah. So, and I think she did that well.
Yeah. Claire's got a hand up. Yeah.
Yeah, and I just wanted to put in there that I'll try and pull into the quality report some of the work we're doing to ensure we're capturing some of that data. So things like serious incidents, we're now asking providers to include ethnicity to make sure we're not missing a previously hidden theme and any inequality. And what I can do after Thelma's challenge is pull that through into the report so you can visualise what we're doing. We're also doing a similar piece of work with complaints.
That's really helpful, Claire. Thank you. Any other points? I'm not getting any takers. Okay. Risks identified during the meeting. Iram.
Yeah, so I've got challenge of COVID, flu and winter pressures and any potential impact on recovery and transformation of services and further development of the ICT. And also leadership and workforce issues in relation to diversity within the BAME community.
Okay, so I would argue that actually they were all incorporated within our existing risk register and BAF, but perhaps, David, have you got any other thoughts on that?
I'd agree, Nicholas, they are. We just need to just focus on them, but they're part of the work that we've got covered.
Okay. Okay, unless there are any other points, I'm actually going to bring us in exactly 2 minutes early. There we are. The wonders of virtual. And despite all the technical issues, many thanks for any of you that were still dialing in and observing us. We hope the technical issues didn't spoil your enjoyment too much, but you can get a part 2 now because at 3 o'clock we've got our AGM with quite a lot of information and reflection on the last year or so, including COVID and many of the things that we've talked about. So thank you very much to all the board, and we'll see you all again at the AGM at 3 o'clock. Reminder for the cancer talk is happening at 1 o'clock for clinicians, and that's a virtual one which Phil Sawyer is leading on. Thank you. Are you able to stop the recording, Iram?